Hello everyone, I am Dr. Utsav Bansal, your ophthalmology faculty at Marrow and a clinical ophthalmologist practicing at Soch Eye Care. This is your ophthalmology image-based revision session. Why has it been done? Because of three factors, I think. Number one, a lot of prayers by a lot of students. Number two, the duality of the uncertainty that has been posed to us by the bureaucracy and the judicial system of India, which has given us approximately 50 days extra to prepare or to get anxious about our upcoming NEET-PG attempt. Now, there are two options I have. One is to prepare or one is to get anxious. To get anxious is easy, to prepare is difficult, but the wise choice will be to prepare. And to help you in that, all of us at Marrow have tried to bring you this last minute revision session, image based revision session, whichever way you want to think about it. This is just to help you keep up the momentum towards that ultimate goal of that date where you sit for those 3 hours and give your best. Now, how I will be proceeding in ophthalmology in this session, I will be discussing a lot of images, but I will be quick with them. Please, again and again, understand this is a revision session. If you are a first time student who is sitting in this class, then I'll hope that you take it in the right spirit and you don't complain that Dr. Utsav has not discussed the images. I'm not going to discuss. This is just a quick revision so that you mentally you are able to, revise. Also, this is a disclaimer at the beginning of the video that all the images are jumbled. I have not put them topic wise or chapter wise or lens images and cornea images, even though I've tried to. A lot of times you will find that they are very jumbled up. This is to mimic the fact that during the examination any question is asked from any subject, right? We are not being given 10 ophthalmology questions and then radiology questions. So I'm just trying to jumble up, not make it easy for you. Let us try to revise to our best potential. Let's start, guys. So this is the first image we see. Question 1, what is the investigation? Let's not go into question 1 or question 2. I'll just keep on asking you. Something is written there. Which investigation can you see being done in the image? So the first thing that comes into my mind is which investigation is being done? Yes, I am examining the fundus. Now, obviously, fundus examination can be done in various ways. So this is how I revise. How can fundus examination being done? The first thing is we can do it by ophthalmoscope. Yes, sir, we can examine by ophthalmoscope. There are two types of ophthalmoscope. What are the two types of ophthalmoscope, sir? There is direct ophthalmoscope, which gives me the center view. And there is an indirect ophthalmoscope, which gives me center plus periphery. That's my quick revision. Sir, what is the other way I could examine the fundus? The other way is I could slit on a slit lamp. Yes. Can you see the patient is positioned on the slit lamp? And I can examine the fundus by using a specific lens. So that becomes the second question. What is the power of this lens, this special lens that the examiner is holding in his or her hand? The answer is it is a plus 90 diopter convex lens. Right? Now, when it is coming to lenses, also remember that the examiners love to ask the power of the lens used for indirect ophthalmoscopy. Now, this is a question which you may remember. The lens looks the same, but it is a bigger lens. It is a plus 20 diopter lens. Do not get confused between the two questions here. Am I clear about this? Move on to the next image, please. What is the investigation which has been shown here? Now you have been shown a girl who's wearing some pair of glasses. One is red, one is green. Yes, that's the answer. These are just red-green goggles. Now, red-green goggles can be used either as such. When they are used as such, what is their use? To examine diplopia. Am I clear? Red-green goggles used as such are for diplopia. Am I clear? But what is the other use of red-green goggles? The child may be wearing this and doing some other test which has not been shown here. Yes, if you are smart, they can be used as part of Wurzford dot test. So if it is being used as part of Wurzford dot test, that means it is being used for binocular single vision or to find out suppression. So now this can be a trick question, though I think this is not a trick question. If you have seen the images, if you have read about the chapter on squint and the basic test, there Wurzford dot test is used to differentiate between the fact whether the patient has binocular single vision or the patient has a diplopia or a right eye suppression or a left eye suppression. If we remember Wurzford dot test, I don't need an image. I can just draw the image. How many dots are there? Obviously, there are 4 dots. One red. Very good. Yes, keep saying along with me. 2 green. No, you don't even need to say, I know you remember already. You are just having a quick last minute revision. This is all a piece of cake. Yes, I know it's a piece of cake, guys. Let's move on to the next image. Again, what is the test being done? Oh, this is a new image. Oh, it takes a second. Sorry, this is a new image. But there are lots of clues here. There are four images, C, D, E, F, but they're all of the same test. Now, what can you say here which is helping you diagnose? There is a special lens with a handle, if I can say so. This is a handle and this is a lens. Now, in all the lenses, you see there is this red mark in different directions, if you can see, but there is this red mark. Can you see? Yes, I'll circle it for you, or I'll just mark it for you in a different color. See the axis. See the axis. Can you see? Now, along with this, you can even see some faint number written here. This should be giving you the clue. This lens is getting rotated. I hope some of you have got it. If not, then please remember this is Jackson's cross cylinder test. This is Jackson's cross cylinder test. Now, what is the use of this test? Yes, we know this now. This becomes a theory question. This is done to refine the cylindrical power of the spectacle. Now, when we use a Jackson cross cylinder test, what is the power of the lens which is most commonly used there? So, the power of the lens most commonly used is minus 0.5 diopter sphere coupled with a plus 1 diopter cylinder, or it may also be a minus 0.25 diopter sphere coupled with a plus 0.5 diopter cylinder, a minus sphere with a doubled power cylindricals. Am I clear about this? In power of plus. That's the question. If this image confused you, please remember that there is another test which is used for refining the cylindrical power. Which other test is used for refining the cylindrical power? Very simple name, very simple name. Yes, that is called as the astigmatic fan test. So see, from one image, see, this is what I'm trying to teach you. From one image, we can try to remember a lot of questions. What is astigmatic fan? It looks like a fan which is opening. Oh, the photo was like this, that there will be a lot of lines drawn like this. Okay, so if I get such an image, it will be the astigmatic fan test. Yes, so that's the beauty of revision. Now, moving on to the next image, everyone identify which procedure is being done. Such images have been given a lot of times in the examination, and a lot of students say a lot of weird stuff about this. This is a pretty simple thing. People who know the answer, yes, you are commenting, I hope. But let's see what is being done. This is the upper eyelid. In the upper eyelid, there is a small hole. That small hole, through that small hole, what is being done? A kind of a needle is being put into the canaliculi. Yes. So what are we talking about? We are talking about the lacrimal sac system, the upper eyelid, the lower eyelid. Both of them have a puncta. From the puncta, what forms, guys? From the puncta forms a canaliculi. This canaliculi, upper and lower, they join each other to form the common canaliculi, which opens into the lacrimal sac, which drains into the nasolacrimal duct. So what is being done here? We are doing probing of lacrimal sac. When is this being done? Probing of lacrimal sac is being done in cases of hyperlacrimation. Or if I can say in simple words, when the patient complains of watering of eyes. Yes. Now, when there is watering of eyes, what can be there? There can be a blockage. There can be a blockage in the canaliculi. There can be a blockage into the lacrimal sac. There can be a blockage into the nasolacrimal duct. Now, when I probe means I'm trying to get a feel of the block. If I feel a soft block tells me that the block is somewhere in the canaliculi. But if I feel a hard block, that means my probe is going through the canaliculi and hitting the nasal bone because the block is in the lacrimal sac. Maybe somewhere here there is a block. Yes. And that is why drainage of tears is not able to occur. So probing of lacrimal sac, soft stop or hard stop. Hard stop means lacrimal sac. Soft stop means canaliculi. Am I clear about this, everyone? This is just the photograph. I don't think they're going to ask you the soft stop, hard stop here. They are basically trying to ask whether you have done this procedure or not, or even if not done, though you should have done it, whether you have seen this procedure being done in your internships or in your third year postings. As I know now, when we were doing our undergraduation, we were apes. Apes means we were not exposed to all such clinical procedures. But nowadays, I see that a lot of our undergraduate students in a lot of colleges, I don't mean to say all colleges in India, but in a lot of majority of colleges, I will say they are being exposed to, such procedures. So this is a, I think, step in the right direction that our undergraduates are getting to see more and more procedures, and they're getting confident in doing basic stuff in all the subjects and not only taking out blood samples and probably giving drips, right? They are no more mosquitoes like we were when we were in our internship. We were called the mosquitoes because all that we used to do was we used to take the samples, right? Okay, so moving on to this image, I think this is a very easy image, but before you say it is easy, I have not asked you which test is it. I have asked you which tests these are. Yes, so there is not one test visible on this image. There are two tests. Yes, you know the name of the two tests also. So what is the first test? Yes, sir. This is the Ishihara chart. No, 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 not the Ishihara chart. This is what chart? Oh, you don't know? This is what chart? Yes, I know all of you are saying it, but answer the second one first. What is this friend written at the bottom of the screen? This is the duochrome test. Yes, sir. This is written in red and green color, duochrome test. What does this duochrome test tell us? This duochrome tells us, or what is its use? It helps to refine the spherical power. The patient should ideally say that both the red and green color visible are of equal intensity, equal clarity, or the letters written in red and green color are equally appearing well. But if they are not, that means the spherical power is either undercorrected or overcorrected. Now, what is this test, everyone? The test for far vision. The test for far vision is known as Snellen's chart. All of us know this. Why such a build-up? No, just like that. I like building things up. Simple stuff. What is the distance of examination? 6 meters, or if you are based in the US, where they don't follow the metric system, then 20 feet. What is the best vision? The best vision is 6 by 6. What is the least vision recorded on Snellen's chart? The least vision recorded on Snellen's chart is 1 by 60. After 1 by 60, what we can do is finger counting close to face. Then we go to hand movement. Then we go to perception of light rays. Yes, that's the basic idea. I don't think there is anything to explain here. How many rows of letter are there? There are 7 rows of letters. What is the angle subtended by each letter? The angle subtended by each optotype or letter from its respective distance is 5 minutes of arc. Please remember this, 5 minutes of arc, each letter from respective distance. Now, I hope you remember these respective distances. If not, then I'll just write them quickly for you. The uppermost row is 60, the second row is 36, 24, 18, 12, 9, 6, and 5. I think that's all. That's all you know. Have I done a mistake? No, I haven't done a mistake. Yes, that's all. That's right, right? So that's the image here, duochrome test. Apart from duochrome test, which other test can you do to refine spherical power? Refine spherical power. What is the other test? A very common test. Yes, all of us know the name. That is the pinhole test. The more commonly done test, if I can say so, pinhole test. Yes. Now, let's move on to the next image. Identify. Now, oh yeah. What is this? This is a choroid. No, what is this? I don't know. What is this? This can either be two things. If you are getting confused, you should get confused only in two things. Number one, fat prolapse. Number two, dermolipoma or lipodermoid, whichever way. Now, this may be a fat prolapse or a dermolipoma. How do you make sure? First of all, if they're asking you in an MCQ in a paper, they're not going to ask you fat prolapse. They are going to ask you dermolipoma. So I will close my eyes and answer dermolipoma. But remember that dermolipoma usually is unilateral. Number one. Number two, it appears yellowish white. I know in this image it is bilateral, but even if you see carefully, it is more in one eye, that is the left eye, and it is very less in the right eye. It is a yellowish white firm mass. Next, it cannot be pushed back under eyelid. Okay. If it is a fat prolapse, you will be able to push out, but then you will be able to push it in and it will be visible at a globule here. But if it is a dermolipoma, you won't be able to push it back. Okay. Because it is fixed with the conjunctiva below. It is not mobile. So these are the differentiating features. I know you should be able to perform an examination ideally to be able to differentiate between a fat prolapse and dermolipoma, but essentially this is how you will answer. If such an image comes, you will answer dermolipoma, as simple as that. What is a dermolipoma? It is a choriostoma. What is a choriostoma? It is choriostoma is an X kind of tissue present not at the X place but at a Y place. Yes, at a different place where it is normally not present. That's all, right? Now, excision is the treatment, though rarely we do it. Now, let's see this image, an image that everybody should be able to answer. Number one, what is visible? An eye is visible, iris is visible. But in the center of the iris, we see some whitish color. That means the pupil is not appearing black. That means there is some opacity behind the iris or the pupil, that is lens. That means it is cataract. All right, sir, we know it is cataract. But what are we trying to ask you? Which sign? And based on sign, what is the correct diagnosis? So what are we trying to see here? Any sign? Yes, see, if we see carefully, when light is being thrown, the pupillary margin or the iris is casting a shadow on the lens. If there is a shadow over lens, what does it tell us? It is which stage of cataract, mature or immature? Immature. Am I clear about this? If it was a mature cataract, it would have swollen up. There would have been no space between the iris and the lens. The lens would have pushed forward. If it was a mature cataract, the lens would have pushed forward. If it would have pushed forward, there would have been no space to cast a shadow. But in immature cataract, the lens is situated posterior. So there is a lot of space to cast the shadow. Are you getting my point? The difference? Why shadow over lens? This is what we are taught in third year postings. This is what is being asked in this image. I'll just rub the red marking. All right, I hope you're able to see clearly. Yes, what is the treatment of choice for cataract, or what is the only treatment for cataract? Surgery, which surgeries are done? We already know SICS, no. Phacoemulsification, yes, that is the most commonly done surgery nowadays, or a new surgery has come which is called FLACS. What do we do in this? We implant an IOL. IOL is made up of PMMA or acrylic or silicone. Acrylic, what are the powers? All that you should know. I'm not teaching you theory again. Yes. All right, a new image. What is the diagnosis? Let's see. You see a pus point below the eye, somewhere between the eye and the nose. What is here? What is here? What is here? Yes, lacrimal sac. So this is a case of dacryocystitis. And based on the redness and the pus, you know it is an acute exacerbation or an acute attack of dacryocystitis. What has formed in acute dacryocystitis? An abscess. Yes. And the lacrimal sac is normally present here. So where is the pus pointing down? Yes. Pus point inferiorly. Am I clear? Due to gravity, the pus will accumulate inferiorly in the lower part of the lacrimal sac. Yes. So this is a case of acute dacryocystitis with abscess being formed. If the abscess is not treated, what it will result in? If we don't treat it, it can result into a fistula. Fistula is dangerous. Yes, we don't want it. So now the question comes, how to treat this case of acute dacryocystitis with an abscess? Now, first of all, what we should do is we should give oral antibiotics. Normally given are augmentins. Yes, amoxicillin plus clavulanic acid. Yes. Now, after oral antibiotics, they calm down the infection. Then what should be done, unless you want to give it a chance to progress to a fistula? Incision and drainage. But we cannot do it at this kind of stage where the pus point is there. Yes, we need to reduce the infection also. So both the things are done. Or if oral antibiotics fail, then also incision and drainage is the only option left. But what is the definitive treatment? of acute dacryocystitis or dacryocystitis. See, what is dacryocystitis? Inflammation of the lacrimal sac. Why is inflammation of lacrimal sac occurring? Inflammation of lacrimal sac is occurring because the drainage is blocked. And where is the blockage? Nasolacrimal duct. Yes, because the nasolacrimal duct is blocked, because there is watering of the eyes, which is leading to microorganisms coming there, bacteria coming there. Most common being Staphylococcus, Pneumococcus, and Streptococcus. That is why we need a definitive treatment. So the definitive treatment is DCR. Through DCR, we are able to create the opening between the eye and the nose, in short, and thus we are able to let the tears drain. Am I clear about this? Yes. Dacryocystorhinostomy. Now, moving on to the next image. Oh, okay. Colorful image. Wow. Wonderful. In eye, some colorful image is rare. We usually work in black and whites. So what is the investigation here? Sir, I don't know. No idea, sir. Oh, is there any clue, sir? Oh, yes, there is a clue. Clue. See the clue. See the clue. That's what you need to find in an image. Clue. Simulated keratometer. So they are telling you that this has something to do with cornea because keratometer readings are also being given. Then they are showing you colors and they are giving you a scale for the colors. That a blue color is showing you 40.5 diopter power of the cornea. 42.5 green color, red color, and maroon color. So they are showing you the corneal curvature. Yes, power of the cornea or corneal curvature. The power of the cornea normally depending on the curvature is around 43 to 44 diopter. But here we see in the vertical axis 90 degree to 270 degree, it is forming an red color. That means the power or the curvature is more. It is more steep. So basically we have mapped out the corneal curvature. That means what have we done? Corneal topography. Sir, but corneal curvature is keratometry. So see, keratometry we don't make a colored map. We make a colored map in corneal topography because basically we have examined the surface. But all I'm trying to tell you is there are a lot of key clues here which are telling you that this is something to do with the cornea. Corneal curvature, keratometry, we have seen images. If not, I'll show you again how they are done. This is the output of corneal topography. Now what it is showing you? It is showing you astigmatism. As I just now explained you, in the vertical curvature, it is showing you a steeper axis or a steeper power. Yes. Now, what is the use of it? Use of it is, I hope you understand, to examine the corneal surface. But in which diseases do we use it? We essentially use it in diseases like keratoconus. When we are going for any refractive procedure like a LASIK surgery, LASIK surgery should not be done in cases which do not have a normal ideal cornea like in cases of keratoconus. So practically speaking, see, this is where you use it. Yes, before every case of LASIK, I will perform a topography. We use a machine called as pentacam normally, right? Now, why are we using it if it is a case of keratoconus, if there is some other kind of corneal irregularity, abnormality that we have not been able to see on our slit lamp? This will become visible in corneal topography. And then if it is not a suitable cornea, the chances that it will land up in an ectasia post-surgery are high. So we do not opt for such cases as ideal cases of being candidates for LASIK surgery. So very important investigation and a photograph which can be asked in the future. Yes. Now, let's move on, please, to the next image. Oh, another new image, a difficult image, I'll say. I know. Which instrumentation is this? We are talking about this blue color thing. Okay, if I want to put an arrow, this is this blue colored thing. This royal blue colored thing that you can see in the image. So what are we trying to show you? We are trying to show you that this whatever blue colored instrument is, it is trying to dilate the pupil or stretch the pupil. Yes? Can you understand this? So you know the use of it. It is used to dilate pupil. But sir, why are we dilating this pupil, sir? Dilatation of pupil can be done by mydriatics. But there are a lot of cases like diabetic patients because of peripheral neuropathy. The pupillae muscle, the dilator pupillae muscle is very slowly responsive or unresponsive. When we need to dilate the pupil, let's say we want to do a surgery, the pupil does not get dilated. Without a pupil dilated, the surgery is impossible to do. Yes. That is where we need an instrument like this. This is just one of the methods. This is called as Malyugin ring. Okay. So the use is to dilate the pupil intraoperatively. Am I making myself very clear? There are various other ways. What are the other ways? You can use iris hooks. You can use intracameral adrenaline. You can do pupilectomy. Okay, so there are various ways, but Malyugin ring is one of the popular or the common ways through which a lot of surgeons will dilate the pupil intraoperatively, do their surgery, take out the ring. Okay, so this is an injector through which we can put it, then we can remove it through this injector again. So that's why this is an important image, sir. Why, sir? We have never seen this, sir, because that's what the trend we have seen proceeding, that a lot of intrasurgical or pre-post surgical images are getting asked these days. So that's why such an image for all of you. Now, moving on, please. Very simple, I think, image with sign and what is the diagnosis. Now, with sign, please remember in this image, the clue is that the light is being thrown from this side. Now, if you can understand this, light is being thrown from this side. Now, what can you see? What can you see? Anyone who can see? Yes, we can see an arrowhead of light falling over the nasal iris when the light is being thrown from the temporal side. And this is known as Rizzuto's sign. Very good, sir. Now, if you're able to make out the sign, Rizzuto's sign, can you tell me the diagnosis? Rizzuto's sign is seen in keratoconus. Very good, guys. I know you have to answer very quickly, but this is a revision session. Again, I am saying this is a quick revision session. So now, as soon as keratoconus comes into my mind, oh, what is the main important sign? Oh, yes, there was another important sign. What was the important sign? This was the important sign. What can you see? Another V-shaped or arrow-shaped. See, a lot of arrows in this. A V-shaped downward bulge of the lower eyelid known as, very good, guys, Munson's sign. So this is known as Munson sign. What is the diagnosis? We already know keratoconus we are discussing. So now when we discuss about keratoconus, what is the other question that comes into my mind? The other question that comes into my mind is, what is the investigation of choice? So sir, the investigation of choice is, as we just now discussed, corneal topography. Yes, that is what we discussed, that the use is to diagnose diseases like keratoconus. But what is the initial treatment? Initial treatment, I'm asking. You say there is nothing like treatment of choice in keratoconus. Yes. What is the initial treatment? Yes, the initial treatment is C3R. But what else can be done? If you remember, there is another surgery called as intacs which can be done. There is another surgery which can be done, which is known as keratoplasty. Yes. What is keratoplasty? Corneal transplantation. Please remember all these things. Just a little bit about your keratoconus. Yes. Yeah. Moving on to the next image. Okay, so we have been thrown head on into retina now. What is the diagnosis? Okay. And what is the investigation? Investigation means, okay, so in this image, they are asking us, they have given you one fundus image and they have given you an additional image of which investigation. So what is this investigation first? Yes, very good. All of us know this. This is an OCT image, optical coherence tomography. Now, what are they showing you in both the images, optical coherence tomography and the fundus image? Let us first focus on the optical coherence tomography. In the optical coherence tomography, you see that there is collection of fluid in the subretinal space. Now, here you see that the macula, I'll use a different color. It's a very difficult image to see on the fundus, but if you see in this area, carefully, it's a difficult fundal diagnosis. That's why we use an OCT. In this area which I have marked, it looks as if it is slightly elevated, that there is, kind of an elevation in this area. So macula has been elevated due to collection of fluid in subretinal space. Diagnosis becomes CSR, central serous retinopathy. Hear my words carefully, sir. What if only the fundus image comes? See, the examiners also know that you are not Einstein's. I am not an Einstein. You are not an Einstein. When I see this, I also have a doubt whether it is CSR. In live fundus examination, I know it can be CSR, but the confirmation is only through an OCT. That is why both the images will always be given. So don't think that the examiners are fools. No, they are not fools. They know what can be diagnosed how, and that's why they're asking you. Okay. Now, What is contraindicated in CSR? Please remember, in CSR, steroids are the most common risk factor. That is why they cannot be given in the treatment. That is a blunder. But steroids can be given in a similar disease, which is known as CME or cystoid macular edema. I hope you remember this. Yes. Now, the question which was asked a lot of time back, I think, with such an image was, if you have a case of CSR, the pathology is in which layer of retina? If the fluid is collecting in subretinal space, then the pathology has to be in which layer? Yes, the outermost layer. Outermost layer is retinal pigment epithelium, or the outermost layer of retina, number 10. Right, guys? Okay, let's move on. Now, when we see this image, okay, which surgery? See, the surgery is being done in the, okay, is this the lens? Is this an IOL? Is this an IOL? Is this a cataract surgery? Is this cataract? Is this cataract? Is this cataract? Is this showing you cataract? No, this is not cataract. No, this is not IOL. Look more carefully. Look more carefully. Look more carefully. This is a part of the cornea, intracorneal, that we are taking out. This is a lenticule. Both these images, you can see the same thing. This is a lenticule. So now, which surgery can it be? A lenticule, intracorneal lenticule. Lenticule basically means a button or a small piece. Yes, this surgery is either called as smile or silk. So, okay, if you are not able to comprehend it, yes, you are. It is done in cases of myopia. So to treat myopia, we have two basic surgeries. What are the two basic surgeries? Number one is excimer laser-based surgeries. Excimer laser-based surgeries are called as LASIK or PRK. And the second are ND glass laser-based surgeries called as lenticule extraction. And if it is a lenticule extraction, there are two names for this lenticule extraction surgery based on the names of the machines which are made. I'll just make a name, and this is Smile or Silk. All right. So this is a newer technique. A lot of patients and a lot of students are asking us, is it better than LASIK? So no, it is not better than LASIK. It is just new. It is not necessary that everything new which comes is better. That's the underlying point. But yes, this is another surgery which is possible to do in cases of myopia. Right? Now, moving on, please. Okay, very easy question. Identify. I think this is no-brainer. Yes, everyone. Yes. Ectropion. This is probably just to ease you out. Yes. Then, okay. Entropion. Do I need to define them? Okay, entropion. Entropion is inward turning of the eyelid. You can see that the eyelid is turned inwards. Oh, I'm so sorry. Ectropion is outward turning of the eyelid. The eyelid is turned out. What a sham. Easy go. All right. Okay, let's move on to the next image. What is the procedure you see being done here? Oh, okay. Anyone? So in the image you cannot see, but he's Dr. Arora. He's our retina specialist, and the clue is given there. Though I think a lot of clues are there. Anyone? Okay, very good. Somebody said, sir, green laser. Sir, you have taught us there is something called as argon green laser. And sir, this laser is used to perform pan-retinal photocoagulation. So, sir, whether you say pan-retinal or not cannot be defined by the image, which should depend on the question which is asked. But at least you know the procedure is argon laser photocoagulation being done. Just because of the clue that you can see green light. And how do you know that the light is being focused onto the fundus or the retina? What do you see? Dr. Arora is wearing something on his head. What is he wearing on his head? Indirect ophthalmoscope. How do we know further he is wearing an indirect ophthalmoscope even in this pose? He is holding a lens in his hand. What is the power of this lens? Plus 20 diopter convex lens. That means he is using a laser mounted along with an indirect ophthalmoscope to focus this argon green laser onto the fundus or the retina, and that is telling us that this is an argon green laser pan retinal photo coagulation being done. Yes. So see, every image comes with a lot of clues. Now, All these images are asking you to be present in the OPD again and again, again and again. You should have seen this. Once you see that, you will never forget it. You have read about it. If you have seen it also, it's like 1 plus 1 is equal to 10, not 2. Yes. Now, the next question that I have written on the screen is, what is the wavelength of this laser? We know the laser is argon green, so the wavelength is 532 nanometers. This we know. Yes, that's all done. As simple as that. Now, what other procedure is argon laser used to do apart from pan-retinal photocoagulation, if anyone remembers? A very important procedure that argon laser is used to do. It is used to perform laser trabeculoplasty. Laser trabeculoplasty, if you remember, is the treatment of choice for prophylaxis of open angle glaucoma in other eye. Yes, I hope you remember this. Right, guys? Done? All right. Let's move on. Okay, simple question. Diagnosis. What is the diagnosis here? Very simple question. One answer. What is the answer? It looks like somebody has spit onto my conjunctiva. That's the answer. Bitot spot. Bitot spots are seen in, yes, sir, vitamin A deficiency. Sir, do I need to again go over the most revised topic, that is night blindness? I don't think so. Please remember X and X1A, X2, X2A, X2B, X3, blah, 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 whatever, right? Please remember all that. You know all that. This is X1A, Bitot spot. X1B is xerosis. All right, conjunctival xerosis. Let's move on to the next image. I don't think there is anything else I can discuss about this. Let's make it a quick revision again. All right, so moving on to the next image, guys. What is the diagnosis here? Is it an injury? Is it a defect? Obviously, it's a defect. It's not an injury. Some part of the upper eyelid is missing. Yes, this is called as eyelid coloboma. Coloboma means malformation of some part of the structure of the eye. Now, colobomas are common in either the eyelid or they are in other structures. So, eyelid is an appendage. Eyelid is not the eye. So the colobomas of the eye are congenital malformations, but the eyelid colobomas, they are absolutely different. They are under the cleft lip, cleft palate kind of pedigree. Am I making myself very clear? So even though both of them are colobomas, but the cause is different. Okay. Now, eyelid colobomas usually occur at the junction of the medial and the middle two-third. They are not going to occur laterally at the junction of the medial and the middle two-third, more common in the upper lid. They are commonly associated with golden hair syndrome, and also they can be seen as part of the Fraser syndrome. Okay. Now, apart from the upper eyelid or the eyelid, where else colobomas are seen? Let us see another image. Let's see this image. What do you see in this? Yes, you see a beautifully deficient iris inferiorly. That means our diagnosis is iris coloboma. Most common location for colobomas of the eye, including iris coloboma, is inferonasal. Am I clear about this? Now, where can colobomas occur in the eye? Number one, into the iris. Number two, basically they are in the fundus, or I can say fundal. Now, fundal obviously means optic nerve coloboma. It can be a retinal coloboma or a choroidal coloboma. Yes, so I'm just writing it as a fundal coloboma. Now, see the question. Idamann's classification. This is for which coloboma? This is for fundal coloboma. There are 7 types of coloboma depending upon the area it has affected or the amount of affected area. Coloboma, it gives an excavated appearance because of the absence of the retinal or the choroidal tissue, and the name of the classification, as is written here, is Idamann's classification. Now, the last question that remains to quickly revise it is, which structure gives the appearance of coloboma but which is actually not a true coloboma? Remember, lens. A lot of times along with the iris coloboma, you will even see that there is a notch in the lens. That's part of the lens is deficient, but it is not a true coloboma. It is just a coloboma, or just a appearing coloboma, right? It just appears like a coloboma, not a true coloboma. Am I clear about this? Yes, guys. Let's move on, please. Let us see this next image. Okay, the question is which IOL. So do we see an IOL in the image? Yes, we do see an IOL. Now there are two clues in this. Which IOL? Which IOL are we asking about? Yes, are we asking about the material of the IOL? No, we are asking essentially about which IOL. So there are two types of IOL. Yes, where can they be implanted? Either in the posterior chamber or in the anterior chamber. Yes, so we are basically asking you whether it is an AC IOL or a PC IOL. Yes, so what is this, AC or PC? Whether you see this IOL in front of the iris or behind the iris. That's the first clue. Sir, we see it in front of the iris. That means it must be AC IOL. But sometimes the PCIL may pop out into the AC. Yes, sir, that can happen. So what is the defining clue? The defining clue is the shape of the haptics. Yes, sir. So if we see the haptic, this is coming like this, and then it is again bending. So if we see, it forms an S shape. If we take it like this, it forms an S shape. So that means we are looking at an ACIOL. I'll just rub this S shape for you so that you can pause the video probably and try to make it out. All right. If you're still not clear, then please see there are the two types of images we see without being put in an eye. This is called as the optic. This is called as the optic. The haptics are different. This haptic we call as C-shaped haptic. When we see a C-shaped haptic, we know we are talking about a PCIOL. But when we see an S-shaped haptic, as I've just shown you, that is known as an ACIOL. So that's the difference. That is what we are trying to see in the image. This is an ACIOL, anterior chamber intraocular lens. Now, what is the specific complication which occurs along with an ACIOL? The specific complication, yes, is UGH syndrome. People who may remember uveitis, glaucoma, and hyphema syndrome. Because this lens is resting over the iris is continuously moving, it is chafing, and due to chafing, uveitis is occurring, glaucoma is occurring, and even hyphema. Hyphema means collection of blood in the anterior chamber can occur. Moving on, guys, to the next image. All right, so we have been shown an image in which primarily we have been shown the eyelid and the conjunctiva, and we are being asked the diagnosis. Focus on the anatomy. As I always say, if you see the anatomy, you will be able to diagnose. What is the diagnosis here? Anyone can tell me what is the diagnosis? Okay. Slow, but yes. What is the answer? Yes, it is a case of angular conjunctivitis. Angular conjunctivitis. Why it is angular conjunctivitis? All the problem you can see is it here at the lateral canthus. It is not an angle, but it is called as angular conjunctivitis because anatomically it is making an angle. Yes. Now, what is the cause? What is the specific bacteria for angular conjunctivitis? Yes, it is Moraxella. Moraxella Exenfeld. Yes. What is the specific treatment? Zinc boric eye drops. These are the specific questions that can be asked, as can be seen in the photograph. What is the clinical feature? That is excoriation at the medial and the lateral canthus, both this or this. This is what occurs more commonly at the lateral canthus rather than at the medial canthus. Moving on to the next image, guys. Diagnose. Oh, beautiful photograph. Don't do right? It's a beautiful photograph. If you're a doctor, what can you see? It is beautiful because it is trying to tell you that it is a less dangerous disease. It looks as if a tape was put and it is being removed, but it was not a tape. Yes, this is pseudomembranous conjunctivitis. That is how we differentiate between a pseudomembrane and a true membrane. Yes, guys, basic teaching. A true membrane bleeds on removal because the tissue of the true membrane has become one with the stromal tissue below it. But pseudomembrane can be removed easily without any bleeding, and that's what it is showing you, that the membrane is being removed from the upper palpebral conjunctiva without any bleeding. That means it is indicative of pseudomembranous conjunctivitis. Moving on to the next image. What is the sign seen? I think it is pretty clear. If not, then I'll mark it for you. This is the sign that they are asking you. You can see that the conjunctiva looks swollen. But which conjunctiva are we talking about? We are talking about bulbar conjunctiva. So the bulbar conjunctiva is swollen. What is it known as, guys? It is a very important sign in a lot of cases of conjunctivitis. Yes, I'm waiting for the answer. Yes, very good, guys. People who know, you must have answered by now that the answer is chemosis. Yes, swelling of bulbar conjunctiva, and it is indicative of conjunctivitis. Moving on, please. Okay, all of us know this. I'll not even ask you the diagnosis. All of us know this. Yes. I think this is as I always say, one of the topics which we spend maximum time studying during our undergraduate years. I don't know why, but anyways. So this is a case of pterygium, a triangular growth of the conjunctiva over the cornea. Okay, I'll write cornea in a different color if it is not visible. Conjunctiva over the cornea, a triangular shape. Now, what is the difference between the two photographs? The difference is the cause of loss of vision, and that is what we want to ascertain. That is what we want to learn. What is the difference? The difference is in the size of the cornea, or the portion of the cornea which has been covered by the pterygial tissue. So, as we will be able to see in the image, I will say number 1 and I'll say number 2. In the image 1, we see that it is a large pterygium which is coming towards the center of the cornea and has even covered the center of pupil. So I will write center of pupil affected. Okay. But in photograph 2, we see it is a smallish pterygium. By no means it is small, but smallish compared to number 1. It does not cover pupil. All right. So if it does not cover pupil in number 2, that means light can go through the center easily. There is no blockage. But here light cannot go. Light has been blocked. So the loss of vision here is block of visual access. As simple as that. But in image 2, there is no block of visual axis. Light can go inside through the pupil. Then why is the problem there? So the problem will be in only dark time. No, we are not talking that. We are just saying in daytime, let's say, why is there a problem? The problem is because this fibrotic tissue is pulling on the cornea. It is changing the curvature of the cornea. And thus it is causing a high degree of astigmatism. Am I making myself very clear? So is it loss of vision, blurring of vision? Yes, all of them are the same. Yes. So this is what we want to understand based on the images. I have explained you again for the nth time. Please, please, please. This is a very, 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 very common topic to be asked because pterygium is very common in the dry and dusty areas of North India like Gujarat, Rajasthan. And that is why a lot of questions are asked from it. Yes. Now, moving on. Next. Okay. Yes. Very good. I was waiting for this. Identify the surgery or the procedure done. Again, on the lines of the images that are being asked very commonly in the past 2 or 3 attempts, they are asking you procedure based or surgery based photographs. So I've asked you, can you identify which surgery has been done in the patient? The clue I'll give you is here, in between these 2 arrows. This is the clue. Something visible on the sclera, and if you see it is shining, the light has been thrown, it's slightly an elevation, right? It can be seen as a rope or an elevation. Is it a scleral surgery? Sir, sclera to scleritis, episcleritis, I don't know. Try to think of the names of the surgeries which start with sclera. Sir, give us options. No, I don't want you to give options. You should be prepared well enough that you see a question, you don't read the options, and you're able to answer it. That is the level we want. I know it is very difficult to achieve. I was not able to achieve it, but that is the level we want. Now, something to do with sclera, something which is encircling the sclera. See, obviously, I cannot show you the 360-degree sclera, but which is encircling the sclera. This is scleral buckle. Now rake your brains hard. Scleral buckle. Scleral buckle is used in the treatment of retinal detachment. Yes. Retinal detachment can be treated either by tamponade, okay, or by scleral buckle. Tamponade is either done by silicone oil or by gas. Which gas? Gas is either C3F8 or SF6. Am I clear about this? So this is your quick revision through this photograph on the treatment of retinal detachment. Please remember there are 3 types of retinal detachment: rheumatogenic, tractional, exudative, all that theory. Am I clear? But this is the image. This is how a scleral buckle looks from outside. I hope we are clear about it. Yes. Now, moving on. Okay, very easy image. Diagnose. Yes. 2 clues here. Number 1, it's a hemorrhage. Obviously, it's a collection of blood, so it's a hemorrhage. One word is clear. The second is the shape. What is the shape of the hemorrhage? The shape of the hemorrhage, sir, is boat-shaped. Classic case of vitreous hemorrhage. Yes. Or sometimes it may be written pre-retinal hemorrhage. Or sometimes it may be written subhyaloid hemorrhage. All of these are the same thing. Any of the options given are the correct answer. Vitreous hemorrhage, vitreous, that means in front of the retina, pre-retinal, or behind the vitreous, between the vitreous and the retina, that is subhyaloid, boat-shaped hemorrhage. What is the most common cause? The most common cause is diabetic retinopathy. But if they ask you what is the most common cause of this in young adults, then the answer will be blunt trauma. Yes, blunt ocular trauma, fighting. I hope we are clear about this very, very, very simple image. Yes, move on to the next image. Okay, an image which is, I think, related to the previous image. That's the clue I will give you. What is the diagnosis? The arrow is already marked. They're asking you the blue arrow. They're trying to show you something on the iris. Yes, they are. What? What can we do? Hmm? Okay, they are trying to show you some new blood vessels. Very good. So, new blood vessels on the iris is rubeosis iridis. Rubeosis iridis is also known as neovascularization of iris. Rubeosis is derived from the word rubor. Rubor means red, red means blood. Neovascularization of iris, rubeosis iridis. Am I clear about this? Can you see this new bunch of blood vessels here everywhere, almost all over the iris? You can see. Okay. Now, what are the causes of rubeosis iridis based on the? Now it becomes a theory question. Image is solved. The causes, there are two main causes. One is proliferative diabetic retinopathy, and obviously the second is ischemic CRVO. Ischemic CRVO causes the rubeosis iridis and then causes the famous name that is called as the 100-day glaucoma. Now, people who may remember, if they give you this image and they ask you the treatment of the above, then please remember, even though it is rubeosis iridis, but the cause is on the retina, proliferation on the retina. That means the treatment remains pan-retinal photocoagulation. The photograph that we had seen a little while back, argon green pan-retinal laser photocoagulation, which was being done. Yes, am I clear about this, everyone? So please, let's move on to the next image. Okay, easy, very easy. Only one, what is the sign and only one cause? Very, very, very typical image. Yes, sir. This is a case of festooned pupil, sir. Sir, festooned pupil is seen in which disease, sir? It is seen in anterior uveitis, sir. But what if two options are given? And acute anterior uveitis and chronic. Now, what will you like to answer? Let's make it a little more spicier. Yes. So, acute anterior uveitis or chronic? What should be the answer here? Acute or chronic? Yes, guys, chronic. See, in the first episode of uveitis, you will not get a lot of synechia forming. Posterior synechia form, if you remember, see again, this is a posterior synechia, this is a posterior synechia. Posterior synechia will form with repeated inflammation or with a chronic dull inflammation. Yes, they are not going to form during an exacerbation only. So please remember this. What is the treatment? You know, steroids plus atropine both need to be given. There is no treatment of choice. You know the other signs, you know the nodules, the Cope nodules, Busaka nodules, and all those things. You know, please, 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 choretic precipitate. So try to remember all those signs about uveitis or anterior uveitis. Moving on to the next image. The sign is Book-Thalmos and the diagnosis is congenital glaucoma. Blue eyes. Yes. What is the earliest sign of congenital glaucoma? Hazy cornea. Hazy cornea appears bluish due to the stretching of the eye, enlargement of the eye. The cornea becomes bluish, obviously, and the sclera thins out. Sclera also becomes bluish. So everything is bluish. What is the treatment of choice? We already know it's a combined procedure: trabeculectomy plus trabeculotomy. Right, guys? We all know about all these simple questions on congenital glaucoma. Moving on. Let's see this image. What is the sign? What is the sign, guys? What is the sign? What is the sign? What is the sign? Sir, where do we focus? Is it an eyelid question? No, it's not an eyelid question. This is sclera. This is cornea. The question is here. The first point is where to look. You need to know where to look, right? So, What do you see here? You see here that at the limbus there are gelatinous dots or deposits. Yes? Now you know the answer. I know you already know the answer. I'm just wasting time probably. No, I'm not wasting time. What is the sign? Yes, guys, the sign is Horner Trantas dots. Eosinophilic deposits seen in which disease? Suggestive of, or seen in which disease? Suggestive of VKC, spring catarrh. Vernal Keratoconjunctivitis, also known as spring catarrh, more common in an allergic conjunctivitis, more common in spring and summer season in boys 5 to 15 years of age. But my question is, what is the differential diagnosis? Let's say we're presenting this case. What would have been the differential diagnosis? Another sign at limbus which you can confuse with. Let us see another photograph. Yes, this is the differential diagnosis of the previous photograph. Again, see, this is the cornea, this is the sclera. The problem again we are trying to identify is at the limbus. But what is the difference between in the two images we see? In the previous image, I'll go back, there were deposits, small elevations, dots. But in this image, do you see any elevations or dots, or do you see some depressions? Can you see it? They look like hollow depressions. So if you see limbal depressions, that means they are remnants of limbal follicles. There were limbal follicles. Now no more they are there. This is known as, not Horner-Trantas dots, this is known as pits. Very good. Herbert pits. Remnants of limbal follicles seen or known as Herbert pits, suggestive of the disease, which is a endemic disease called as trachoma. Safe strategy. Please remember, surgery, antibiotics, facial cleanliness, and environmental hygiene. A for antibiotic and A for which antibiotic? Azithromycin, 1 gram single dose. Right? Please remember all this. And that gives us the answer of differential diagnosis. The differential diagnosis is trachoma. These are the two signs which usually students confuse with. That's why I put the photographs together so that you can try to remember them. Now, please remember, what is the treatment for VKC or spring catarrh? The treatment is pretty simple. You need to give antihistamines plus mast cell stabilizers, that is dual action drugs. But along with that, initially, in the initial part, you also need to give topical steroids. Because why, sir? Why topical steroids need to be given? Because there is a lot of itching in these cases. The dual action antihistamine plus mast cell stabilizers, they take around 4 weeks to start acting. So in the initial period, to give relief from the complaints, that is the itching, we have to give topical steroids. All right. Now moving on, please. Next. Okay, what is the diagnosis and what is the test to confirm? Okay, so this is the arrow. If you can see here, this is what we are talking about. This cornea. What has occurred? Is the iris coming out? Let me also see. Nah, iris is not coming out. Nah. What is this? This is a corneal foreign body, bachas. This is a corneal foreign body. Corneal foreign body, probably we are talking about chisel and hammer. Yes. Somebody was working with a chisel and hammer. Some particle came, got stuck onto the cornea. Now that means it is an iron particle. I hope you understand the case, how the examiners build this case from this photograph. Yes, this is very common. A lot of houses, buildings are being built near you. If you are a practicing doctor, right? And almost every week or so, you will see some kind of a labor or a workman coming to you, handyman, workman, mason, whatever you call them. And they will say that something fell into our eye and now it's been 2 days and now we are having some grittiness, some foreign body sensation. And you see that there is a small particle of iron with a rust ring around it. I hope you can see the rust ring around it. Yes. The iron will leach out the iron particles. Can it go inside? No, it cannot go inside. How do you know? You know because of your experience. But when I was a postgraduate, I was taught that in an emergency, if a patient comes like this, who has a corneal foreign body, you also always need to ascertain whether this foreign body has penetrated the cornea or not. How are you so sure? So, which test is used to confirm the penetration? Whether the cornea has been penetrated or not. That test is called as Siddle's test. Siddle's test. This I have taught, if you remember, in the theory on Uses of fluorescein dye. So we stain the cornea with fluorescein dye. If there is a hole in the cornea, the fluorescein dye will leak inside the anterior chamber and the aqueous will also take a greenish color. Yes, but if there is no leak, the aqueous will not be green. That's the basic idea, Siddle's test. Okay. Now, what is the treatment for this? If there is a corneal foreign body, do we need to do a surgery? Do we need to do an MRI? Do we need to do blah, blah, blah? Nothing, blah, blah, blah. That's why I'm saying all you need to do is you need to take a 26 gauge needle and remove the foreign body. Yes, you take it, see, you take it like this. You take it parallelly to the corneal plane. You don't take it like this. You can penetrate the cornea and then you just go and flick it out. You just go and flick it out. Obviously, it's experience, but it is very easy to do. You will also be able to do it. Come to me, I'll teach you, right? So 26 gauge needle and remove the foreign body. Removal of the foreign body using a 26 gauge needle. Obviously, we will give topical anesthesia and then do it. Otherwise, the patient will not be comfortable. Right, guys? I hope we are clear about this. This whole thing is called as siderosis. I hope you know that. Iron anything, but this is actually a very low grade siderosis because the iron just leaks into the corneal stroma only and it creates no problem in the future. Now, next image. Anyone can tell me what is the diagnosis? Very easy. Diagnosis. Yes, sir. The diagnosis is it is iridodialysis. Thank you, sir. But then, what are the signs you see here? I see two signs here. Yes, sir. I see a D-shaped pupil. Very good, sir. So, iridodialysis, that is detachment of iris from the ciliary body, leads to D-shaped pupil. And it leads to two sources or 2 points of light going inside the eye. Thus, it leads to double vision or diplopia. I, D leads to D and D. Just a fun way to remember. No, if you don't like it, it's all right. I won't write it, please. I'll just remove it. Iridodialysis leads to D-shaped pupil and diplopia. Why does it occur? All of us know this now. No use writing again and again. But still, I have to write. It is seen in cases of blunt ocular trauma. All right, guys. Next image. Okay, moving on to the next image, everyone. I think continuing with the same line or lineage of questions that we have been doing for the past two questions. What is the sign seen? Very, very good photograph. Yes, yes, all of us know this looks like a Kung Fu panda, so we call it the raccoon eyes or the panda eyes. Apart from ophthalmology, we do study it in FMT also, forensic medicine also. So raccoon eyes or panda eyes, but I don't think photographs they are showing you. Yes. So what is the cause of this? What is the diagnosis? The diagnosis is in other subjects we call it the fracture of the base of skull, but here we say this is the fracture of roof of orbit. So please understand the roof of orbit or the base of skull, they are the same thing. And even though it is rare, but sometimes when it occurs, especially in cases of RTA, you can get such an image. And two simple questions on this. Moving on to the next image, into the same lineage. What is the sign? Yes, all of us know this is an X-ray image, which is showing us teardrop sign. I think this is no more a question which is difficult to anyone. This is probably something which everyone knows who has passed under graduation. What is the diagnosis? What is teardrop? Okay, so this is right, this is left. Now you can see that there is a fracture here, due to which the orbital contents of the left side are falling down, and that is why it looks as if it is a teardrop. What is the diagnosis? The diagnosis is a blowout fracture. Now, what is a blowout fracture, guys? All of us are aware already. I'll just repeat it. Blowout fracture is the fracture of floor of orbit. Yes. Now, what is the most common fracture of orbit? Most common fracture is the floor of orbit fracture. This we know. The thinnest wall is the medial wall, but the most common fracture is the floor of orbit. Moving on, right, guys. Another important sign that you can see, what we can see here, we can see that the pupil is dilated, but on the lens, we have some iris pigment or pupil pigment which is stuck. And this is known as Vossius ring. Yes. So I hope you're getting the gist. These are all trauma images, just intermixed, orbital trauma or ocular trauma. Vossius ring. What is the cause? The cause is, that's what we are saying, blunt ocular trauma. Right, guys? No confusion about these simple images, I hope. Moving on, what is the diagnosis? Okay. What can we see in this image? Let us change the color. green color. We can see this is the sclera, this is the cornea, but the iris is visible only in the superior half. In the inferior half, I cannot see the iris because of collection of blood. That means what can I see? I can see hyphema. Hema means blood and hypopion, hyphema. Hype means collection in the anterior chamber. What is the source of bleeding? What is the source of bleeding? Very simple question. This is my cornea, this is my iris. Now the blood has collected in the anterior chamber. That means the blood has either come from the cornea or from the iris. Where has it come from? Iris. So yes, the source of bleeding is circulus arteriosus major, or the major iridal circle, or the major circle of arteries of the iris. There are two blood vessels, major and minor, and that is what they're trying to ask you, just the major part here. There is no big deal here. What are the causes of hyphema? Obviously, causes we are asking. The most common cause is blunt ocular trauma. But can it occur in other cases? Yes, hyphema can occur in a lot of cases. Hyphema can also occur in cases of corneal ulcer. Very rare, but yes, it can occur. It can occur post-surgical. It can occur in cases of uveitis, specifically due to herpes simplex virus. Okay, so there are a lot of causes of hyphema. Recently, we had seen ACIOL question where UGH syndrome is there post-surgery, right? So there are a lot of causes of hyphema which can be there. So please remember hyphema photograph, nothing difficult, I hope. Now, okay. So photograph, which looks like a photograph which was asked in the recently conducted INI-CET May 2025 attempt examination, but it is not the same. What do we see here? We see some kind of a hole in the center with a plastic kind of a device. Is it an IOL, and over that something, some sutures in the cornea? What is it? So if this is a new image for you, this is an image of keratoprosthesis. Keratoprosthesis means artificial cornea. See, this photograph we have moved ahead of keratoplasty now. Keratoplasty means corneal transplantation from a donor or a dead person. We take a cornea and we implant it into a living person. But what if the corneal transplantation is not being successful? It is contraindicated. It is at last an organ transplantation. It is getting rejected. Transplantation rejection is a very common phenomena. Yes. In those cases, in such cases, we need keratoprosthesis. So what is the indication? Multiple graft rejections. You have done keratoplasty multiple times and every time there is graft rejection, or specifically in cases of Stevens-Johnson syndrome or ocular cicatricial pemphigoid. Okay, these are some of the indications of a keratoprosthesis. This artificial cornea, or the most common, this is known as Boston K-Pro. K-Pro is the short form for keratoprosthesis, and it was made in Boston, one very beautiful city in the United States of America, and that is what is called as Boston K-Pro or Boston keratoprosthesis. All right. Now, what is this essentially? I'll just try to teach you that there is a central area, which is the optical area through which light goes inside. Then there are two plates to this, a front plate and an end plate, between which we take a donor cornea. See, donor cornea is required. It's not an absolutely artificial device, but we are not suturing the cornea into the host cornea. So we are just placing some donor tissue in between the two plates of the K-Pro, and then we are suturing the K-Pro via these interrupted sutures to the host cornea. Which sutures are used, if you will ask me? Nylon 10-0. Okay, these are absorbable sutures, nylon 10-0. These sutures are used in any case of cornea to cornea suturing that is done. Interrupted sutures, as you can see on the screen. Right, guys? Am I clear about this? All right, something you learned probably. Diagnosis, very simple image. I hope you have seen it. The upper eyelid and the lower eyelid, they are connected by a band of tissue. Upper eyelid, lower eyelid, eyelid margins connected. Yes, fusion. Very good. That's the key. Think about English. Ankylo. Blepharon. Ankylo means fusion. Blephar means eyelid margin. So this is a A specific form of ankyloblepharon where there is a single strand. This is called adamantum ankyloblepharon. You can just pull the eyelids apart, it will break, and no problem as such. All right. Now, moving on. Two images, very common images. I know all of us know them, but they're important to revise. That's why we are revising these images. First of all, image number one, the diagnosis and the dye use. Then image number two, the diagnosis and the dye use. Yes, let's start with the answers. Very good. I know you're already written the answers or spoken the answers at least. I'll take probably 30 seconds to write them. Dendritic ulcer. Dendrites can be seen branching pattern. Green colored illuminescence in a orange dye. Blue light. Yes, now you're writing it correctly. Then green fluorescence. Yes, which dye are we talking about? Fluorescein dye. Now am I correct, my children? Yes. Okay. Now what is image number two? What do we see here? A geography. Yes, we see a geographic ulcer and rose Bengal dye. So, dendritic ulcer, geographic ulcer, and the dyes which have been written on the screen, these are two basic questions. All of us know that we are talking about which virus here? We are talking about herpes simplex virus, right? Now, I'll show you another image. What is this? This is not specific to herpes simplex virus, though it is more commonly seen in herpes simplex virus. This is a case of, again, you can see the dye is the same. What is the dye? The dye is still the fluorescent dye. This is a case of SPKs, or as we can say, superficial punctate keratitis. Why are we using the word punctate? Puncta. Puncta means dot-like. So we can see a lot of dot-like lesions. These can be seen preceding bacterial ulcers also, but they are more common in herpes simplex virus, we can say. So all these three that we saw, SPK plus dendritic ulcer plus geographic ulcer, all these three have the common treatment. What is the common treatment? The common treatment is, yes, I know you remember, I'm just trying to revise it because it is an important thing. Acyclovir 3% eye ointment. That's the key. And it has to be put 5 times per day for around 10 to 14 days. That's the dosage of it, right? What is not given here? Steroids are not given here. Why are steroids not given? Because they interfere with the epithelial regeneration or the healing of the epithelium. But in the other lesions of herpes simplex virus, like we know, necrotizing stromal keratitis or endotheliitis, all those cases steroids shall be used because the epithelium is not damaged. Basic, right? Moving on. Okay, an interesting image. What do we see in this image? Is this a iron foreign body? Is this a chisel and hammer injury? Like we did, I think 3 or 4 questions back. No. As you can see, the pupil is stretched. See, this is the main giveaway. The pupil is stretched towards this side. That means the iris is pulling the pupil. That means the iris has prolapsed. Yes. So this is a case of iris prolapse. This is a case of iris prolapse. Must have occurred either due to corneal ulcer or due to, or rather, a consequence or a complication of corneal ulcer. Corneal ulcer, if not treated, the cornea will become thin and the pupil will prolapse or the iris will prolapse out, or it can be a case of penetrating trauma. Something penetrated the cornea large enough to, create a pressure difference and make the iris prolapse out. All right. Am I clear? Obviously, surgical treatment has to be done. You have to reposition the iris inside and then you have to suture the cornea. If you don't do it, the iris will become atrophic. Then there will be no other way but to cut the iris. And, that's the way it proceeds. All right. Now, moving on. Next question. What do we see here? The sign. Anyone? It is marked. The arrow. The arrow is already marked. This is what we are asking. So, what are we asking? Can you see? We are asking about this white band that can be seen. Where it can be seen? Conjunctiva. So start thinking conjunctiva. When in doubt, at least start thinking about the chapter. In conjunctiva, what have we read about this? A band, a line, a line. As soon as I say a line, this word comes into my line. Arts line. At least I'm making an educated guess. I've read this word. It's a line. It's an arts line. And yes, that is what it is. It is a line of cicatrization. Trachoma is the diagnosis. Trachoma is unique because the inflammation and the healing both are taking or both are progressing or both are occurring at the same time. Yes, there is inflammation occurring causing sarcogrin follicles, but at the same time healing has cicatrization has started, and you can see arch line has formed. So this is the line of cicatrization most commonly seen between the junction of the lower 1/3 and the upper 2/3. Obviously it's flipped out, so it's the other way around, and that's the diagnosis. Right now, what other sign can be seen in trachoma? See, this is also seen in trachoma. But what is this? Along with Arch line, you can see another important sign. What is this sign? See this. Cornea is avascular, we all know. But here, what are we seeing? We are seeing superficial vascularization. When we are seeing superficial vascularization of the cornea, what is it known as? Yes, it is known as, very good, simple word, pannus. And that's the important image of pannus, superficial vascularization of the cornea, very clear image of pannus, right guys? Now, moving on to the next image. Okay, we are continuing with conjunctiva, it seems. What can we see? Oh, nice. It's very easy. Yes. Sir, we can see cobblestone papilla. Very good. If you can see cobblestone papilla, cobblestone means like the footpath. Can you see all those hexagonal shape kind of footpath stones or bricks placed together? And if you are in India, you will also see a lot of stones have been already lost even before the footpath has become functional. So that's what you can see probably, right? So that is why they are called as cobblestone papilla. What disease are we talking about? We are again talking about VKC, or we are talking about spring catarrh. We've already seen Horner Trantas dots occurring in the same disease. Yes, but this is almost pathognomic or diagnostic. Both the images you can see different yet same. Right, guys? Now, next. Okay, a before and after. Which test is being done? What is the difference? Before and after, that means some test is being done. Before the test, after the test. The difference I can see is I can see redness here. Okay, I'll use a different colored pen, please. I can see redness here. I can see no redness. Or can I say blanching? Hmm. But as soon as I say blanching, people who cannot understand will also be able to understand. So see, essentially that is what images are. Images are just your, how do I say? Images are just making you speak, right? We are so fond of speaking to our friends, but so afraid of speaking in the classes or in the postings that we have forgotten how to describe. Image-based questions are nothing but descriptions. If you're able to describe the image, you are basically saying out loud the answer, the theoretical answer, or the ratification that you do. And as soon as you hear the words, your mind will give you answers. That's all. So images should be decoded into words. Once you're able to do that, your job will be easy. So we are saying that we have done a test after which there is blanching of blood vessels. That means what have we done? We have used phenylephrine. Yes. So this is phenyl 2%. Phenylephrine test. Or as we popularly say, vasoconstrictor test. Using 2% phenylephrine eye drops. All right. Now, why are we doing it? We are doing it to differentiate between two conditions, that is episcleritis and scleritis. In both the conditions, we know theoretically there is a difference, reddish and bluish, but practically there is no difference. So, if the blood vessels are able to constrict, that means blanching occurs, then the diagnosis is episcleritis. But if blanching does not occur, then the diagnosis becomes scleritis. Yes. Continuing with the same train of thought, let us see this image on the screen. What do we see? We see again that the problem is in sclera. Can you make out? There is a bluish elevation in sclera. See, again, I am trying to convert. If you're finding it difficult, I am trying to convert a bluish elevation of sclera. Now, what do you know about blue and sclera? We know that the sclera appears blue when the sclera becomes thinned out. Now that means the sclera is thinned out here. If the sclera is thinned out, that means the sclera has atrophied in a small part, not in the whole eye. We are not talking about ophthalmos. Yes. In a small part, if the sclera has become atrophied, that means there may have been a chronic inflammation. That means it can be a case of scleritis. But why is it bulging? It is bulging because it is a specific type of scleritis which is called as necrotizing anterior but without inflammation. I know, an inflammation without an inflammation, but nonetheless, that's how we describe it. And this is known as, you know this name, scleromalacia. Malacia means thinning, sclero means sclera, and due to the thinning, it has protruded out and it is about to, or it can perforate. That is why known as scleromalacia perforans. More common in females suffering from rheumatoid arthritis, chronic inflammation. Am I clear about this, everyone? Yes. Or you can also call it a staphyloma because staphyloma is bulging. So is it a staphyloma? Yes, it is bulging. But when we look beyond the staphyloma, we need to know the cause of staphyloma. So if you talk about the sign is staphyloma here. Yes, bulging. If I call bluish elevation or bulging, I am talking about a staphyloma. But the examiner is not interested in asking you this word here, staphyloma, right? The examiner is asking you the blue color, the bulging, why is it there? What is the cause, right? And the cause is scleromalacia perforans, or the disease is scleromalacia perforans, right? I hope you are able to distinguish between a classic case of a scleritis versus the normal cases that we get, that we have seen here before and after of episcleritis, right, guys? Let's move on, please, to the next image. Okay, what is the sign and what is the cause? Easy image. If you don't understand, see the two arrows have been given for you, the marked for you to make you look at that specific portion where we want you to look. What can you see here? You can see a ring. But sir, this is iris brown color. No, see the iris. The iris is gray color. In this individual, the iris is gray color. Over that gray color, you can see a golden brown ring. Yes, sir. Now we get the answer. This is a Kayser-Fleischer's ring. What is the cause? All of us know the cause is Wilson's disease. Kayser-Fleischer ring is deposition of copper. Where is copper deposited? Obviously in the cornea, in the Descemet's membrane. I am writing DM, Descemet's membrane. Please remember that the Kayser-Fleischer rings begins superiorly, then inferiorly, then it becomes lateral. It starts superiorly, then it affects the inferior part, and then finally it affects the, so I can say this. This is how it affects. 1, 2, 3. Am I clear about this, everyone? And it is seen in all the neurological cases of Wilson's disease, but it is not seen in all the cases of hepatic diseases of Kayser-Fleischer ring. A question has been asked previously, I think into 2020. Please go through that question. That was not an image-based question. That was a theoretical question only. I've told you all the important points that were included in that question anyways. All right, moving on. Okay, just one more question. Wilson's disease causes which cataract? Sunflower cataract, all of us know that. Just came into my mind, so just ask you that question. All right. Now, moving on, diagnosis. All right. What can we see on the image? We can see a cornea, but we can see that the cornea has some opacity. They're asking you what kind of opacity? What is the name? Yes, anyone? Anyone? All right. This is called a Reth pattern ulcer. You should have known this. Reth is that specific arrangement of flowers which is placed on the coffins of the martyrs, right, of the army or whatever martyrs we have. We respect them a lot. Yes, and that's a round collection of flowers, and that's what it looks like, right? So a round collection of flowers with all the flowers pointing outwards like this, and that is why it is called as a Reth pattern ulcer. I hope you can make it out. Yes. Now, the answer, the important question, the second question is what is the cause? So, all of us know the cause is nocardia. A very specific bacteria causing a very specific shaped ulcer, nocardia. All right, everyone, moving on, please. Okay, so we have been given an image now and we are being asked what is the test. This image is indicative of which test? We have done a question previously where we had mentioned this. Yes. Yes, guys, very good. This is a test being done which is called as keratometry. Keratometry is used to measure the corneal curvature. Keratometry used to measure the corneal curvature. Corneal topography gives you a colored printout, but corneal curvature measurement gives you just a value, and this is what you see when you're doing the investigation. You see keratometric Myers. Now, what is important to remember in this image? Keratometric Myers are giving you the correct reading when there is a single minus sign between the two vertical Myers and when there is a single plus sign. It's just a little fuzzy in the image, but that is what is showing you. Single minus sign between two vertical and a single plus sign between the two horizontal Myers. Keratometry used to measure corneal curvature. Am I clear about this, everybody? No confusion here. Yes. All right. Let's move on to the next diagnosis and signs. Okay. I think it should have been the other way around, signs and diagnosis. Yes, first we need to see the signs, then only we can diagnose. Let us see the signs. What can we see? Obviously, we can see an opacity on the cornea. It looks like a corneal ulcer. If it looks like a corneal ulcer, what kind of margins do we see? Do we see a well circumscribed or do we see feathery margins? I think, sir, we see feathery margins. So it will not be wrong to say that we can see feathery margins. Then, sir, we see a satellite lesion. Yes, sir, we see a satellite lesion. The diagnosis is already there, I know, but we have been asked the signs by the examiner, so we have to describe or enumerate them, right? All right, it's theory paper. What can we do? Now, then we can see these two arrows, and with these two arrows, we can see a ring. What is that ring known as? That ring is known as Wesley immune ring. So we can see a lot of important signs which make it clear that it has to be a case of fungal corneal ulcer. No confusion about this. Yes. What is a drug of choice for fungal corneal ulcer? This also we know, sir. It is 5% natamycin eye drops. 5% natamycin eye drops. All right. Any confusion in this? I hope not. Right, guys? Done. So this image you may have seen various times in various subjects in derma, in medicine, in microbiology, and maybe I have also shown you. So what is the sign first of all? I know you know the diagnosis, probably you're thinking about the nerve, but what is the sign? Yes, that's what we're interested in. First of all, the name of the sign. So the name of the sign is Hutchinson's sign. Very good, guys. Now, what does Hutchinson's sign tell us? Hutchinson sign tells us that if the tip of the nose is involved, then the ocular involvement chances are much higher. Yes. What are we talking about? We are talking about herpes zoster virus, keratitis or infection, or popularly called as shingles. Herpes zoster virus is notorious because it involves the fifth cranial nerve, division 1, that is the ophthalmic nerve, and very often patients are left debilitated even after the resolution of the scar and everything by post-herpetic neuralgia, for which we need to probably start them on gabapentin for a long time. Yes, and that is what is an important thing. How do we treat it? The best treatment is in cases of herpes zoster virus keratitis, if I'm talking about, and even otherwise, if you're talking about dermatology, if within the first 72 hours we are able to begin the antiviral therapy, either with oral acyclovir 800 microgram 5 times a day or with famciclovir 3 times a day, right? And the minimum treatment runs for around 10 to 14 days. That's the quick recap of the photograph. Moving on to the next photograph. All right, simple question, diagnosis. Now, this is how I teach you. I know all of you know the answer probably, but still I'll ask you. This is what they're asking you. It's like a band, yes? So yes, the answer is band-shaped keratopathy. I hope this is one of the easy images that has come across during this image-based revision session on YouTube. B for band, B for which layer is involved, Bowman's. This we know. K for keratopathy. If we sound out the phonic for keratopathy, K for deposition of calcium. So deposition of calcium in the Bowman's membrane of the cornea. The treatment is chelation with EDTA. This we know, right, guys? So pretty simple condition and pretty simple image for all of us. Moving on, please. Okay, I think one of the easiest photographs now. This is a nodule formed in the upper eyelid. The diagnosis is chalazion. All of us know that chalazion does not affect the eyelid margin. Yes, it is a painless condition. Why is it a painless condition? Because it is a chronic inflammation. Which type of inflammation? We like to call it lipogranulomatous. It is a granulomatous disease like tuberculosis, like sarcoidosis, a chronic inflammation comprised of macrophages, right? And which gland is involved? Meibomian gland. We know all this, right, guys? Pretty simple condition to remember. As I say, if you want to remember it, you can say CML. C for collision, M for meibomian gland, and L for lipogranulomatous inflammation. But how do we treat it? So to treat it, we can, let's say, get this photograph. So what is being done here? We see a clamp. A clamp has inverted the lower eyelid. Then we have given a cut, a vertical incision, and then we have a collision scoop, which is not seen in the photograph, which is just a miniature version of an ice cream scoop, which can scoop out all the contents of the collision. So what is the treatment which has been shown into the photograph? If you ask me, it is incision and drainage, right? Now, do we have another treatment option? Yes, we have another treatment option, which is gaining a lot of traction because it seems less painful to the patient as an option. Intralesional triamcinolone. Triamcinolone is a steroid. A steroid is going to take care of the inflammation, and without any need for incision and drainage, we can treat it, but it is successful only in small cases. So if they ask you what is this instrument, this is a collision clamp, right? And along with it, we use also a collision scoop. These are the two instruments which we use during this procedure. As shown in the photograph, all the meibomian gland, the mucus contents, they are coming out, right? The sebum is coming out rather, right? Moving on to the next image after collision, and the two wonderful images of the collision. What is the sign seen in this image? What is the diagnosis? And what will the torchlight show you? Seems like a difficult photograph, but it is a very easy photograph once you focus. What can you see? Some kind of abnormality, this too you can make out. What is the abnormality? If I can draw for you here in probably simple words, normally the iris is stretched flat. But in this case, if I draw a diagram, it looks as if the iris is bent forward. Yes or no? Now, I think the answer will be very easy. This is called as iris bombay. Yes or no? When the iris has bent forward, or when the iris is bowing forward. So if the iris is bowing forward, what is our diagnosis? Our diagnosis is obviously angle closure glaucoma. Yes, that's what we know about angle closure glaucoma. So now the question is, if we throw light, torchlight onto this kind of an image, let's say we are throwing light from the temporal side, what will occur to the light? Will the light be able to cross over? No, the light will not be able to cross over. And this sign is known as eclipse sign. So see, once you are able to identify what the examiner is asking you in terms of what is the image, it becomes a theoretical question. Now the examiner may ask you anything about angle closure glaucoma. He may ask you based on the above image, what is the treatment of choice, what is the drug of choice, anything. The treatment of choice is you create a hole in the iris, laser iridotomy, the aqueous will start flowing from posterior chamber to anterior chamber. The drug of choice is you have to reduce the IOP because the IOP is very high, so you give IV mannitol followed by pilocarpine drop. So we know all this. So see, again, in images, the challenge is not to answer the question. In images, the challenge is to understand what is the topic we are talking about. Once you're able to understand the topic, it becomes a theory question. That's all. It is as simple as that. So when you see an image, try to think of the topic. And that's what you need to practice when you're practicing also. All right. Now, okay, now we see this image. Okay, and they've asked you which investigation is this. In this, the left side image is showing normal endothelium high cell density. In the second image, it is written very low density, high surgical risk. And in the third image, it is written polymegathism, extended wear contact lenses. Now, had the text not been written, I could have presumed it is a difficult photograph. But with the text, it becomes a very easy photograph because of these two words, endothelium and polymegathism. Now, think about these two words, endothelium and polymegathism. Can you understand what it is this? This is a case of, or these are photographs of corneal endothelium. When we have corneal endothelium photographs, what can we do? We can count the endothelial cells. When we count endothelial cells, which investigation are we doing? Specular microscopy. Or otherwise, you should have thought it looks like a microscopic image where cells are seen. And the answer straight away would have been specular microscopy, right? There are both the ways of doing this image. Now, let us also understand that this is the normal size of the endothelial cells. This means image 1. Here, the cells have become enlarged because some cells must have been lost. But here, there is polymegathism. You can see a lot of cells, they have had to become very large in size in order to plug the gap that has been created by loss of endothelium at two spaces. Am I making myself very clear here? Am I clear about this? Yes. So this is specular microscopy and some images of it if they ever come into your entrance examination. Move on to the next image, everyone. Okay, what do we see? It looks like a beautiful painting. No, it's not a painting, it's a photograph. Yes. What is the diagnosis? So again, what do we see here? Can I say these are breadcrumb-like deposits, for lack of a better term? Breadcrumb-like opacities or deposits, and with clear spaces in between, right? Am I clear? Obviously, cornea. We are talking about the cornea, yes. Any understanding of what it could be? These are like breadcrumbs, or if I don't want to say that word, but if you can think of any other word, granules. Yes. So these are like granular deposits or opacities which are interspersed with clear spaces, and they affect only center. See, periphery is not had has not been affected. If you see, periphery has not been affected. Only the center has been affected. These are the characteristics of the famous granular corneal dystrophy. Okay. A very common stromal corneal dystrophy, and that is what is given to the question. Now, my question to you: granular corneal dystrophy, when we are talking about what deposits are seen, obviously it is stromal. If you don't remember, I am writing it here. But deposits of what are seen? Deposits of hyaline are seen. Yes. When deposits of hyaline are seen, which dye can we use to stain hyaline to confirm our diagnosis? We can use Mason trichrome stain. Yes. And this is which stain? That's the question. Mason trichrome stain. This is the cornea, this is the corneal stroma, and hyaline is deep red in color. On Mason trichrome stain, hyaline is deep red in color. So these are all the hyaline deposits that you are able to see. So that means they may not give you a corneal photograph of granular corneal dystrophy. Instead, they may give you this photograph, and through the histopathology, they may try to ask you a question on corneal dystrophy. This is a possibility because these are the kind of clinical questions, if I can quote it, that are being asked more and more, and that is what we are afraid of. But nothing to be afraid of. If your histopathology is strong, if your ophthalmology is strong, and they are strong, always believe yourself, you will be able to do them. Don't worry. See, I'm just giving you images, but almost always with image based questions, there are certain clues given in the 2 or 3 liner question also. So please use both. Okay. Now, moving on to the next question: which investigation, which instrument is this? If you have ever seen this, you know the answer. If not, then it will be difficult. Have you seen this instrument? Okay, so this is a keratometer. This is a Bosch and Lomb keratometer. This is the most common model used clinically in India. This is a manual keratometer. These days we have automatic keratometers. We rarely use this, but when in doubt, we have to go to through this. So this is basically investigation is keratometry. Please remember this because again, this is something which you should be able to identify if you have ever gone into your ophthalmology departments and postings. This is a very omnipresent instrument, and that is just the reason that this image can come in your examination as a simple spot question, if I can say so, right? Moving on, guys. Okay, this image shows you which surgery has been done. Surgery. And what are the indications of this surgery? So, surgery which has been done, anyone? Anyone? Yes? Okay. So, this is an image which shows Intax surgery. What is Intax full form, if you remember? Intracorneal stromal ring segments. Now, if we focus on the image, we will be able to see that there are ring segments between my arrows. This is the first ring segment, and this is the second ring segment, right? So two ring segments have been implanted inside the stroma of the cornea. Why inside the stroma? Because stroma is the thickest. And these basically stretch the cornea outside. So we are doing this surgery basically when we want to stretch the cornea or flatten the cornea, right? Intact. I hope you're able to understand. So now based on the fact that we have to flatten the cornea, what are the indications? There are two primary indications, if we can remember. The first is it can be used as a treatment of myopia, though seldom used now. And the second more common indication is keratoconus. These are the two indications that we can use Intacs for, right? Moving on to the next image, everyone. Again, which surgery is this? So I think it is a pretty easy image. We have discussed a similar image in the questions gone by. Yes, some sutures onto the cornea, and if we see it carefully, it looks as if there is one cornea from here till here. You can even see a small furrow, and this is the second cornea in the periphery. So this second cornea, this is the host cornea, whereas this whole cornea, this is the donor cornea. Now, what we have tried to do, we have tried to suture the donor cornea with the host cornea. So basically, we are taking a cornea, we are implanting it into another person. So we are talking about which surgery essentially? We are talking about corneal transplantation, or we are talking about keratoplasty. See, obviously, keratoplasty can be either a full thickness keratoplasty or a partial thickness keratoplasty, depending on the indications, whether it's a complete keratomalacia, then it will be a full thickness penetrating keratoplasty, or it can be a lamellar keratoplasty or a partial keratoplasty if we only need to change the endothelium and the descemet membrane. So depending on various causes, it can be divided into two types, partial thickness or full thickness basically. But whatever the keratoplasty is, the suture used is 10-0 nylon. It's an absorbable suture, and the media used to transport the donor cornea. The media is obviously for storage and transport of donor cornea is either a moist chamber or MK media. If MK media, McCoffrey Kaufman media, and both these are maintained at 4 degrees Celsius, and these are up to 72 hours storage. Up to 4 days, some people say, but the better answer is up to 72 hours. Okay, that's how we store the cornea. Long storage of cornea is usually not required because the demand for corneal transplantation far exceeds the supply. So the fact that we have a cornea which we are storing for a long time is, I think, rare, right? Even though for long-term cryopreservation can also be done, and for medium-term storage, we have media like Optisol, GS, and others. Okay. Now, so that's your simple question. Keratoplasty. What are the indications of keratoplasty? See, any case where the cornea has become useless. Useless means completely opaque. The final treatment is keratoplasty. That's all. It is as simple as that. So in every corneal disease, if the treatment is not done on time, the end treatment possible will be keratoplasty. Okay. Now, next image. Okay. What is the sign? What is the diagnosis? And culture they've asked. Okay. So let us see. First of all, sign. We see a ring-shaped abscess. Yes, pretty simple. A ring-shaped abscess. Now the only question is ring-shaped abscess is seen in which condition? So I think it is pretty pathognomic almost. We have not read this name anywhere else in ophthalmology. Acanthamoeba keratitis. And acanthamoeba keratitis is more common in contact lens users plus dirty water. I think this has been drilled into our minds by now. We are no more confused in this. And the culture is acanthamoeba is a parasite. Please remember that is why it is non-nutrient agar enriched with E. coli. Yes. So I've written in short form NN agar, non-nutrient agar, which is enriched with Escherichia coli. That is the culture. Also, one dubious question is what is the drug of choice? As I have always told, I'll just repeat PHMB 0.02%, but it is not commercially available. That is why we have to make a solution of chlorhexidine eye drops 0.1% out of a solution of chlorhexidine mouthwash, right? That is what the answer is. Moving on to the next image. What is the sign which has been marked by the arrow? I think it is pretty simple. They are asking you, what is this? What is this? First of all, let us answer. What is this? What is this? What is this? This is collection of pus in the anterior chamber, hypopyon. Pyo means pus, hype means in the anterior chamber. So again, just like hyphema, this is hypopyon. Now, if I ask you what is the differential diagnosis of a hypopyon, meaning what? Meaning, what are the causes of a hypopyon, or what can be the causes? See, obviously, the first of all is it has to be an infection for pus. So we know hypopyon is seen in cases of corneal ulcer. Where else can you see a hypopyon? One very important cause is endophthalmitis. Yes, these are the two that come to the top of my mind. They can be, or hypopyon can be seen in a lot of other cases also, but these are the two differential diagnoses that come at the top of my mind. Now, out of the two, just based on the photograph, if you ask me, what will I say? I am not tilted towards anything, but to me, it looks like it is a post cataract surgery image. I know it is difficult for you to comprehend, so I am more keen on answering endophthalmitis. But there would be a question with such an image, which will either be giving you a cataract surgery history or not. If it is not giving you a cataract surgery history, the answer will be corneal ulcer. But if it is giving you cataract surgery history or any other surgery history, the answer will be endophthalmitis. Yes. Now, endophthalmitis. What does endophthalmitis cause? Inflammation of the whole eyeball except sclera. Am I right? Yes, the whole eyeball is inflamed. When the whole eyeball is inflamed, what do you see? You see conjunctival congestion, you see corneal haze, you see hypopyon, and along with that, you see vitritis. One, two, three, plus vitritis, which we cannot see in this photograph. Yes, we know endophthalmitis can occur acute onset or long onset. Acute onset is due to CONS, and late onset is due to Propionibacterium acnes. What I am interested in this name, if you remember, evisceration. Evisceration is the treatment where the whole eyeball is removed except the sclera. And there is another name which you may be aware of, enucleation. Please remember or learn to remember the differences between the two. Evisceration, removal except sclera. Removal minus sclera. Enucleation, removal plus optic nerve. Right, guys? I hope we are pretty clear about this. So that is why evisceration is done in endophthalmitis and not enucleation, but enucleation is done in retinoblastoma and not evisceration. All right, everyone, are we clear about this? Yes. Simple image. I hope hypopyon, not a big deal. What is the difference between hypopyon in bacterial ulcer and fungal ulcer? We know bacterial ulcer is either a mobile or sterile, and fungal is immobile and sterile. Moving on to the next image. Okay, next image is a three-part image. Number one, number two, number three. What is number one? What is number two? And what is number three? Let's see. Number one, left eye. What can we see? Anyone? Left eye. We can see a white colored pupil. What is a white colored pupil known as? Leukocoria. Number two, what can we see? We can see a fundus image. But in the fundus, we can see some large tumors. Yes, fundus, large tumors growing endophytically. So can I say endophytic, growing inside the cavity? Endophytic retinal tumors, just for the lack of any other description. Number three, it's a CT scan MRI image where we see intraocular calcification, posterior segment calcification. Any confusion? Still confused? Okay. Let us see the next. Number four, number five, histopathology images. Number four, classic clear lumen surrounding cells known as Flexner Wintersteiner rosettes. Number five, what do we see? Homer Wright rosettes or pseudo rosettes. They do not have a clear lumen, they just look like them. And that is why they are popularly called as pseudo rosettes. No, 1, 2, 3, 4, 5. I don't think anything is left. Even after this, if it is left, then I don't think you have studied ophthalmology at all. Then I don't think this session is going to be of help to you. Then you need to go back to the main videos, please, first. All right, guys. So I hope these five images are very clear. Just joking, guys. I hope all of you are able to learn this. Remember this. Flexner intestinal rosettes are pathognomic. Hemorrhage rosettes can also be seen in other tumors. And leukocoria means a white colored pupil, endophytic retinal tumor growth, as you can see. And the investigation of choice is CT scan because it can show you intraocular calcification. And retinoblastoma is the most common cause of intraocular calcification. Also, we remember that 3 drugs can be used. CEV plus what is the treatment that can be done in stage 5? Or if a simple question is asked, what is the treatment of choice? That will be enucleation. So chemotherapy plus this, that is the treatment of choice. All the other things about retinoblastoma are very common. That's the only important tumor that is asked in ophthalmology. I hope you studied in pathology also. Yes. Moving on to the next image. Which investigation is being shown to you in the image and what is the diagnosis? All right. So we are into now black and white territory, right? This is the territory I don't love. I think radiologists love that. I don't love it. But nonetheless, I have to deal with it. So what do we see? We see a black area and then we see some blood vessels or something like that shining. That means the investigation is fundus fluorescein angiography. This much should be clear. I hope. FFA. Yes, fundus fluorescein angiography, when the fluorescein dye is staining all the blood vessels and then wherever there is a leakage or blockage, blah, 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 right? What can we see? So let us try to see. We can see all the peripheral blood vessels. This is, I think, the optic disc, if I'm not wrong, because this is my start of all the blood vessels. All the blood vessels enter and exit from the optic disc. This is a blackish area here. This must be my macula, small leakage there. But I think what the examiner is essentially asking us is this. What is this? A large network of tortuous blood vessels. Can I say? A large network of flower-like florid tortuous blood vessels, which is hyperfluorescent. Yes or no? It is hyperfluorescent. It is shining with all the might it can. That means it is blood. That means it is blood vessels. That means it is basically neovascularization of retina. Neovascularization of retina, I think the first diagnosis that comes into my mind is PDR. I hope I'm not wrong here. Right, guys? So I think that's the way we see an OCT, and this is a very classic image of a very, 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 very progressed, highly progressed proliferative diabetic retinopathy. The patient is probably very late to seek treatment. He would have a very poor visual prognosis. Right? Now, moving on to the next image. Again, a fundus image. They've asked us what is the sign and then what is the diagnosis and causes. So sign, first of all, what can I see? I'm looking at the optic disc. I think the optic disc looks more or less normal to me. I don't see any defect. I don't see any optic cup is also normal. The blood vessels are normal. They are going out normally. The artery and the vein, the artery and the vein. And I see the macula. Now, near the macula, I see there are a lot of yellowish scattered deposits. So my mind is thinking yellowish, irregular deposits. Yellow means oil. Oil irregular. What is irregular oil? Oh my God, it's very simple. It's exudates. Light bulb, or previously what was called as hard exudates, lipid deposits. But they're in a specific shape. They are in a circular shape, if I can say so. Yes, they're in a circular shape. Sir, this is a classic case of, I have heard about it. This is a classic case of sarcinate exudates. Sarcinate exudates. Sarcinate retinopathy. That's what it gets the name. This is seen in cases of chronic hemorrhages, chronic edema, rather. When there are hemorrhages, there is edema. So sarcinate retinopathy is seen in cases of chronic edema. When there is chronic edema, lipid deposits start forming around them to absorb the edema, to limit the edema, and that is why it gets to be known as retinopathy, and it is usually seen in cases of diabetic retinopathy or diabetes. Causes, if you are asking me cause, I will say diabetes or diabetic retinopathy. That's the case. Please remember this is circular succinate exudate, succinate retinopathy. Now, moving on, please. We have two images on the screen and the diagnosis they are asking you based on both the images. So again, this is an FFA image. I think this much is pretty clear. In FFA, optic disc is seen. Macula, which should have been dark, is not dark. On that, it looks as if it is a umbrella appearance or a smokestack appearance, a cigarette umbrella or smokestack. And then again, we see the other image. It's an FFA image. This is the optic disc. This is the macula. On that, there is an ink blot, as if I had a fountain pen in my hand and I just did this, and that is why my clear diagnosis is CSR. Not a difficult question. Let's not spend time. All right, next image. I think I already know the answer based on the previous question. See this flower petal appearance. I think we've seen this image a lot of times now, and it is pretty clear. It looks like a marigold flower. Gende ka phool, sasural genda phool. There is a song. No, we are not interested in that right now. We are unmarried. Right, very good. No, I am married. You are unmarried. Right. So, most of you are. I'm sorry. Number two, what is the second image? The second image is an OCT image. Now, in this OCT image, what do we see? We obviously see some kind of cysts. To simplify everything, let us say what we can see. If we do that, if we learn to do that, we make our lives easy. So, we have cysts in retina. Cysts in retina along with flower petal appearance should not make it difficult to be a case of cystoid macular edema. Am I clear? In cystoid macular edema, where does the fluid collect? In the outer plexiform layer. What is the treatment of choice? The treatment of choice is intravitreal steroids. The signs are written in front of you: flower petal appearance and cystic appearances. The risk factors, there are a lot of risk factors. That is how we learn it. Run for pride. I hope you remember them. If you don't, I'll quickly go over them with you. R for retinitis pigmentosa, U for uveitis, N for niacin or nicotine, P for prostaglandin analogs, R for retinal vein occlusion, I for Eden-Gast syndrome, D for diabetic retinopathy, and E for epinephrine in aphakia. I know you also know it. Let's move on to the next image. All right, another OCT image, guys. But does this seem familiar? Yes, it seems familiar to me. Does it seem familiar to you? Yes, I hope it does. Okay, it's a pretty easy photograph. What is there? This retina, both are discontinuous. There is a hole in the center, and that's the answer: macular hole. Done. Simple. End. Okay, this is a case of macular hole. How is it treated? Obviously, it is treated by surgery. We have to do vitrectomy so that these pulling forces which are pulling the interlimiting membrane, they are lost. We have to do membranectomy. We have to cut the internal limiting membrane, and along with that we have to do inverted flap closure also. Plus gas in vitreous. So this is what we need to do for the treatment of a macular hole. Pretty simple OCT. Right? Pretty simple. Let's move on. Okay. Now, diagnosis. Again, what can we see? Pretty simple. Let's see again. I know I'm saying simple for everything. It is simple for you. I know that. You are just spending a little time with me here revising this because probably you're bored of reading other subjects and you want an easy subject to study. Am I right? Yes, I am. I hope. So we see two different areas. One is this black colored area which I have marked, and the other is this green color area that I have marked. What is the difference between the two areas? If I say so. In the black colored area, I can say there is a clear appearance of a attached retina. But in the green area, there is a hazy appearance of a detached retina. Yes, curtain flying in front of the eyes. Along with that, I see a very, very, very important sign here, this blue color. What do I see? I see that there is a tear in the retina, a kind of an horseshoe shaped tear. Okay, so it's a retinal tear. Now, when I have a retinal tear, along with that, I have detached retina. So, does my diagnosis need any saying? Retinal tear along with detached retina. Am I clear about this? Yes. The name itself is enough. Rhigmatogenous. Regma means break. Break means a tear. Yes, rhigmatogenous retinal detachment. A very good photograph to make all of you understand, if you have never been able to before today, how will a retinal detachment look on a fundus examination. But which examination has been done? Please remember, in retinal detachment, we need to do IDO, indirect ophthalmoscopy, because we need to be able to see the whole retina from the periphery towards the center, everything. Can we do profile access of this case? Yes, because we know rhigmatogenous retinal detachment occurs due to a tear or a break. So what do we need to do? We need to do laser photocoagulation of break. Done, everyone. Let's move on to the next photograph. You want to slow down? No. Do you want to slow down? No. No, no, no. I know. I'm hearing a lot of no's. Okay. Next image. What is the diagnosis and what is the sign called as? Okay. Diagnosis. So what do I see in this image? Again, let me divide it into two parts for you. Inferior part, where I see a clear retina, all the blood vessels are very easily visible, and the superior part, where all I see are hemorrhages. Okay. So suprotemporal, because this is my macula, yes. So suprotemporal part of fundus or retina has severe hemorrhages, which are giving it an appearance as if suprotemporally we have splashed a tomato. That means it is a case of branch, CRVO. The most common affected area or the branch is the suprotemporal. This we know, and thus we justify our finding. It is a case of branch central retinal vein occlusion. The superior or suprotemporal branch has been primarily affected here. I hope we are clear about this, right? Okay, move on to the next image, everyone. I think this should be a pretty easy image. We have seen it various number of times. This should be easy to revise. What is the investigation? The investigation is pretty clear that the examiner is examining the fundus using a plus 20D lens in her hand. And the investigation is, I'll write the full form, not the short form, indirect ophthalmoscopy. Okay. What is the magnification of indirect ophthalmoscopy? 3 to 5 times, depending on the power of the lens that is used. If a 20 diopter lens is used, it will be 5 times. What is the distance of examination? It is called as arm's length. Just some of the points. All of us know that because the magnification is low, the area of view will be a little wider. So we will be able to examine the central as well as the peripheral retina up to ora serrata. And the patient is lying supine. That can be pretty easily seen in the photograph. So the patient's position is supine in this case. And because it is an indirect ophthalmoscopy, the image formed is almost always real and inverted. Just a quick revision of your indirect ophthalmoscopy. Moving on to the next image. All right, it's a diagrammatic representation where the procedure being shown in the image has been asked. All right, different from retina, different from ophthalmoscopy, right? So what do we see? We see that an eye has been made, and then there are two needles or two injections, if I can say so, going into the periorbital fat, okay, or the periocular fat. But what do we see? We see that this is an extraocular muscle. Let us just label it. It must be an extraocular muscle, EOM. Then between the EOM, we call it the intraconal space. This is the ICS. But outside the cone of muscles, we call it the extraconal space. Yes. So in this image, if I can simplify it, the injections are being given in extraconal space. If the injections are being given in extraconal space and they are being given in both through lower lid and upper lid, That means we must be talking about peribulbar anesthesia. Am I clear about this? Yes. Had the syringe or the injection been shown being given here in this space, that is the intraconal space, then it would have become which? It would have become retrobulbar anesthesia. Yes. But that is not what has been shown. That is what I will delete for you here now. So where has the injection been given? In extracorneal space, and that is why it is called as peribulbar anesthesia. Peribulbar anesthesia is a form of local anesthesia. We all know this. Local anesthesia to the eye. The other way is retrobulbar. So this would have been retrobulbar anesthesia. This is peribulbar anesthesia. This is also peribulbar anesthesia. All right, am I clear about this, everyone? Why is retrobulbar anesthesia not preferred? Because we are going behind the eye. There are chances of damage to the optic nerve, but more than that, there are chances of hemorrhage. There are a lot of blood vessels which are present in the cone, which are supplying the eye. So the chances of hemorrhage are pretty high, and that is why retrobulbar anesthesia, even though it is quicker onset, but it is still not preferred. Peribulbar anesthesia is a safer way of proceeding. Am I clear? I think that's all. This is local anesthesia given before surgeries like cataract surgery. Even though cataract surgeries nowadays can be done in topical anesthesia also. Moving on. Okay, identify. But what is this? What do I identify? I don't have options also. So, okay. So, this is a photograph showing retinal histology or histopathology. Okay. Now they are asking you identify one layer of the retina. I am pretty simple. I start with the topmost layer. I know the mnemonic ING. IOP. That's all. ING IOP2, right? Now, once I've written this mnemonic, it becomes very, very easy for me. This must be internal limiting membrane, a very thin layer you can see here. Then this must be my nerve fiber layer. Then I see cells, a lot of cells, ganglion cell layer. See, that's the beauty. As soon as I see cells, I see a cellular layer. Then after that, I have inner plexiform layer. Then I should have inner nuclear layer. Inner nuclear layer made up of bipolar cells. Again, cells. Again, I can see lots of cells in this layer. This is what we've been asked to identify. Let us continue. Outer plexiform layer, no cells. Outer nuclear layer, again a cellular layer. Then I have photoreceptors. Then I have pigment epithelium. Pigmented layer, that is why it is brownish in color. Right? Can you see how easy retinal histopathology is? Three cellular layers: ganglion cell layer, internal nuclear layer, and inner nuclear layer and outer nuclear layer, all three having cells. Pigment epithelium having pigment appearing brown in color, and that's how you can identify. The only thing is you need to be able to first of all remember the mnemonic. If you remember the mnemonic, half of your job is done. All right, guys, done. That's your identify. This is a very common question. This has been asked lots of times now. You should be able to learn this. This is no more an exotic question, right? Retinal histopathology, the names of the layers and the identification in a image. Now, moving on, please. Okay. Again, a question which is asking us the procedure which is being shown in this series of images A, B, and C. So, what is being shown? In the first image, I don't know what we can see. No, I can. This is us holding at the limbus. Then we have a caliper. What is this, guys? This is a caliper, a measuring device. One tip of the caliper is kept at the limbus and the other is making a point on the sclera. Now the point which had been made on the sclera, we have a needle going through there. Then we have a needle and a hub visible completely going in. That means I am injecting posterior to limbus. Can I say? Injecting posterior to limbus. Piercing sclera. This is what is visible to me. Now, if I say this injecting posterior to limbus, Piercing sclera and pars plana. What is the procedure? I hope it becomes clear to me. It is an intravitreal injection. What is the site of intravitreal injection? Probably I already know. That was the second question which I wanted to ask, but the answer is already here. The site of intravitreal injection is posterior to limbus, 3 to 4 mm, or by piercing sclera and pars plana. When we say posterior to limbus, we can also say anterior to ora serrata. Right, guys? So these are some of the simple questions which can be asked on this image. Again, if you have seen it, you will know it. Moving on to the next image. All right, obviously we are discussing and we are having an image-based revision. So obviously there will be images only, not MCQs, right? So what is the test shown in the image A and B, and what is the diagnosis? Okay, so what do we see? We first of all see ptosis in image A in the patient, and a good amount of ptosis in the right eye. But in image B, we see that there is no ptosis almost, or the ptosis has improved. That means something has been done between both the images, some test, and that test is called as tensilon test. In tensilon test, what do we inject? We inject hydrophonium injection, right? Which leads to improvement of ptosis because the diagnosis is myasthenia gravis. All right, everyone. Yes, simple. All right. I think there is a very popular meme on Instagram also on this. They show a female having like this, and then she suddenly opens her eyes like this. And you may have seen that meme on Instagram. Almost all of you are on Instagram, I know. Right. Next image. What is the sign seen in the image and what is the diagnosis? I think that's the staple of images, sign and diagnosis. It's a fundus image again. As we can see, what we can see in the fundus image, we can see the optic disc, we can see the blood vessels. That means this is the macular area. Now on the macular area, if I can show you just to quickly, there are three zones, right? On the macula, if there are three zones, what can we call it? That's the sign. Anyone? 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 Okay, I'm waiting. Yes. We call it bull's eye maculopathy. Oh, some people are saying, oh, no, you don't need to do. Oh, if probably options had been written, you would have been able to answer it. Bull's eye maculopathy is seen in which condition? Diagnosis. There will be two answers here. One is you already know chloroquine toxicity. Yes. But if you're talking about an ophthalmology disease, then what will be the answer? That is what I am interested in. Stargardt's disease. If you remember what is Stargardt's disease, it is a macular dystrophy. Yes, it's a macular cone dystrophy. Stargardt's disease, where on OCT we see a very important sign which is called as silent choroid sign. And this was what we should know about Stargardt's disease. Simple, right? Moving on to the next image. Okay, similar image, sign and diagnosis. I think it's pretty clear. It's a half fry. As I have told you, on the macula, again, see the optic disc, see the blood vessels. On the macula, there is an egg-shaped appearance. If there is an egg-shaped appearance, this becomes a vitelliform lesion. Egg yolk-like lesion. I think it should not be a difficulty at all. This is a case of Best's macular dystrophy. One of the easy photographs of the fundus, if you know egg, that's what you need to click in your head. Egg on the macula, egg on the macula. Yes. Now, what is the characteristic question about Best's macular dystrophy? That the investigation of choice is not ERG, instead it is EOG, because something called as the Ardence ratio is less than characteristically 1.5 when the normal is greater than 1.85, and that's the basic idea about this image. Moving on to the next image, again the same, the sign and the diagnosis, right? In the sign, what do we see? Again, let us first focus on to the optic disc. Optic disc, blood vessels. Now we look on the periphery. But in the periphery, we are able to see lot of scattered, if I can say so, bony spicule pigmentation. That's the sign. Are you all right, lads? I think I just saw a Scottish movie before I am doing this, so that's why this is stuck in my head. All right, lads. Bony spicule pigmentation. Now, I think once I've written bony spicule pigmentation, the diagnosis is pretty clear. The diagnosis has to be retinitis pigmentosa. It cannot be anything else. Retinitis pigmentosa is which kind of a dystrophy? We already know it's a rod cone dystrophy. R for rod, R for rod, R for retinitis pigmentosa. Obviously, that is what I wanted to say. But rod cells are responsible for night vision. So if I have a rod cone dystrophy, the problem I will have is nyctalopia. And obviously, the famous names along with that, the scotomas. What are the scotomas? The name is ring scotoma, donut scotoma, tunnel vision, blah, blah, blah. We already know all that, right? And that's a quick revision of the retinitis pigmentosa image. Please remember that such an image, even though we read in post graduation, we read when we are doing post graduation in ophthalmology that pigmentation on the fundus or in the fundus can be there can be various causes, but at your undergraduate level, if an image like this comes, there will be only one answer, and that one answer will be retinitis pigmentosa. Let's move on, please, to the next image. In the next image, what do we see? First of all, obviously, it will be written, it is an ultrasound image. Which ultrasound? Now I'm asking you. This is a B scan image. Brightness scan. This looks like a image that you normally see on ultrasound. Yes or no? Even if somebody is pregnant, this is the kind of image you will see, a black and white color and a cavity, right? So this is essentially your lens. This is your retina and this is your vitreous cavity, as all of us know. Now we are asking you what is the diagnosis. So we see that there is a tumor growing attached to the retina. So is it retinoblastoma, sir? This is a case of choroidal melanoma. Okay. Choroidal melanoma presents with this collar stud appearance or called as mushroom appearance. Collar stud is that pin that designer, a lot of people when they wear blazers, they put a pin in that to show off their designs or something, or it can be called as a mushroom appearance. So both are same. We are just poor in English, probably. That's why we suffer. Otherwise, now I hope you can clearly see a collar stud, a button kind of a thing, or a mushroom shape here. Moving on, please. Again, same image, B scan. I think I don't need to explain this to you again. It is B scan. Let us just see what the diagnosis is. Anyone can make out the diagnosis. See, the arrows are already marked. That is what they're asking you. This was your choroid. This was your retina. Now the retina is being detached. So this is a classic case of retinal detachment. A funnel shaped, or we say it a funnel sign, right? Triangular sign, funnel sign. You can see a funnel getting made here, right? And it is a very classic way of retina getting detached. Now, moving on to the next image, diagnose. Which investigation? All of us understand. We have discussed this kind of images, FFA, previously, some time back. What is the diagnosis? Um, I don't know. You tell me. I know you're already telling me. See, first of all, we can see a lot of stop gaps here, right? Then we can see that this blood vessel is completely empty. There is no blood. Can you see there is no blood in all these branches? Yes. That means this specific branch, if you see, there is no blood. This has been blocked. So if I clear it out for you, this is where I will focus myself. That this looks like a case of central retinal artery occlusion or blockage. CRAO, central retinal artery occlusion. Central retinal artery occlusion, the most common cause is atherosclerosis. Please remember, FFA can show you two things, leakage or blockage, and that's what we have discussed in the images. All right. Now, moving on to the next image, sign and causes. Okay. What do we see? We see two signs here, sign A and sign B. Anybody would like to opine? Sign A and sign B. Okay. Some people are saying, sir, cherry red spot. I know, cherry red spot. But cherry red spot at macula, I'll complete the sign. But what is the first sign you can see? What is first sign? See, that is important because cherry red spot occurs due to the fact that there is a pale fundus. As I've explained over and over again, cherry red spot is not the abnormal part of the retina. This is the normal part of the retina. The surrounding retina has become opaque because of translucent, because of retinal edema, pale fundus, and that is why the normal piece of retina is appearing as the cherry red spot, right? Anyways, not going into the explanation. These are the two things you can see: pale fundus, cherry red spot at the macula. You know the diagnosis. Now, what are the causes? For the causes, we have a popular mnemonic. All of us know the mnemonic. Cherry trees never grow tall in sand, mud, and grime. Cherry trees never grow tall in sand, mud, and grime. It does not make sense in alphabets. You have to say the whole line. C for CRAO. T for trauma, but please remember which trauma, that is where questions are made, blunt trauma. N for Niemann-Pick disease or Niemann-Pick's disease. G for gangliosidosis. T for Tay-Sachs disease. S for Sandhoff's disease. M for metachromatic leukodystrophy. And G for Gaucher's disease. Please remember Gaucher's disease is the least common cause. This is the second point where questions are made. We are revising. You should be listening to me. I am writing only. You're not writing. I hope you have already all these notes written. You just are revising with me. Please, please, please focus on my voice along with me. Right, guys? All right. And that's all about this image. A very simple image on cherry red spot. Please remember a lot of questions asked on cherry red spot. These two are the usual culprits as far as the answers of the options are concerned. Now, moving on. Oh, is it a pathology revision class? No. I think somebody has made an error. Oh no, there is ocular association written. So it's not an error. Let me put my mind to it. It is a peripheral smear given. PS means not posterior segment. PS means peripheral smear. So they are asking you what is the peripheral smear examination. Guys, it is very simple. Let us look. Let us look that a lot of cells are discoid shape, but a lot of the other cells, they are having a weird shape. All these cells, I think they are called as spur cells. Am I right? Yes, I think I am. And they're also called as acanthocytes. Yes, I am right. Now I remember. Acanthocyte spur cells called as acanthocytosis. Obviously, what a big deal. But acanthocytosis is also called as A beta lipoproteinemia. A beta lipoproteinemia. Now, acanthocytosis or A beta lipoproteinemia, that is your answer. But question number 2, ocular association. I know, retinitis pigmentosa. The most common systemic disease associated with retinitis pigmentosa is Lawrence-Moon-Biddle syndrome. Then we have Usher syndrome. Then we have Refraction syndrome. But one of the important conditions also associated is acanthocytosis, also known as A beta lipoproteinemia. And that is the way the examiners have asked you a question on innocuous retinitis pigmentosa using a peripheral smear examination image. All right, guys, moving on. Next image, again a fundus image for us. In this fundus image, what do we see? We see some kind of a volcano burning with some lava forming. That is what it looks like to me. No, it does not look like that to me. It looks like a punched out scar. As simple as that. Yes or no? It's a scar and it has been punched out. Now, as soon as I see a punched out scar, there is only one diagnosis: toxoplasmosis. Please remember, toxoplasmosis is the most common cause of posterior uveitis. When it causes posterior uveitis, it causes either the punched out scar as seen in the image, or it causes a famous appearance which is called as headlight in fog appearance. Headlight is fog appearance is seen during active toxoplasmosis, and after toxoplasmosis has self-resolved or you have treated it but late, it leaves out a punched out scar. That's the basic idea of toxoplasmosis in the eye. Okay. Moving on to the next image. Okay. What is the sign and what is the cause? So obviously there are multiple signs in this photograph for me. If they're asking you the sign, they're asking you between the arrows because they have given arrows, obviously. So it should be written here, or it would be written if such a question is asked, the arrows. Okay. Now what do we see in the arrows? Pretty simple. This is my fundus. This is my fundus. But if I see between the arrows, it looks, look at my hands, it looks as if there is a small depression in between. Yes, the fundus is coming, but there is a small depression. Now, if I think about it, it is like this fundus is coming from here, the fundus is coming from here, and I have a depression in between. Or if I see it in another way, it looks as if, just to complete the diagram, that there is a bulge in sclera. Can you understand? The internal view will look like a depression, but the external view will look like a bulge. A bulge in sclera. I think my sign is pretty clear. It is posterior staphyloma. Now, if it is posterior staphyloma, what is the cause? The cause is pathological myopia. Yes. Posterior staphyloma is seen in pathological myopia. Does it justify my answer? Let me justify my answer. This is the optic disc. Around the optic disc, I see a C-shaped crescent of chorioretinal atrophy, temporal myopic crescent. All right, I can justify my answer by another finding. Obviously, there are various other findings. I can see even this blackish appearance, which is called as tessellated fundus. So I think I'm correct. Yes. All right. I hope you have been able to understand this. Moving on to the next image. All right. What do we see in this image? Diagnosis they have asked, and then they have asked the treatment. It is a pretty weird image. But I think the history would have been given. See, I can see the IOL edge here. That patient had cataract surgery. Along with that cataract surgery, after 12 months, after 2 years or whatever, the patient started complaining of blurring of vision. On examination, the following is seen. So now I see there are pearl-shaped opacities. I hope I can see. There's a circular IOL, and behind that there are pearl-shaped opacities. Pearl-shaped opacities means we are talking about Elschnig pearls. We are talking about the complication of cataract surgery, most common late complication, which is called as posterior capsular opacification. See, there could have been a better photograph for PCO. I have lots of photographs for PCO. PCO is one of the common complications. But why have I shown this photograph specifically to you? Because you need to understand that not necessarily always characteristic photographs or easy to see photographs will be asked for you. A lot of times confusing photographs may also be given. What day, what examiner has put what photo, that's your luck. That's all. I know your life is difficult. I know it is, but you have to make the best of it, right? Now, what is the treatment of PCO? We all know we need to clear the PCO by using ND-YAG laser posterior capsulotomy. That's it. All of us know this, right? I think that's all about PCO. There's nothing else. No, PCO, okay. That's what I wanted to say. PCO is also known as secondary cataract or after cataract, but these are misnomers. We already know these are not cataracts. Please remember them if you're naive, if you're new to this topic. Right, guys? Moving on to the next photograph. Moving on to the next image. Next image, what is the diagnosis? What can you see, guys? You can see that there is some kind of a tumorous growth. Yes, can we see this? Between the two arrows, we can see some kind of a small elevated. So can I say it's a tumorous growth or tumor? I don't know. But what do I see along with the tumor? I see that there are some hair follicles coming out of it. Right? So that is the clue. Hair follicles. Are hair follicles, or do hair follicles have any place in the eye, on the surface of the eye, the cornea or the limbus or the sclera? No. So I understand it is a choriostoma. Yes. Choriostoma means a lesion which is presenting with normal tissue of the body but at an abnormal place. So choriostoma, it is a tumor having some kind of hair follicles or skin tissue or teeth or appendages at a different place. So what is our diagnosis? Limbal dermoid. I hope you understand this. Limbal dermoid, a limbus, a tumor which goes from the limbus. Okay. But it will always have some kind of hair follicles visible to you in the photograph to be able to diagnose. Now, what do we need to understand about limbal dermoid? Does limbal dermoid cause any loss of vision in the eye? No, it does not. But if the size increases, see, it is going from the limbus, so it is going towards the sclera and going towards the cornea both. So if its size increases, it can impinge onto the visual axis, or it can cause astigmatism. Astigmatism is the primary thing. Secondly, if it impinges onto the visual axis, it may even lead to amblyopia. So just the simple way, like a pterygium or any other lesion which will come onto the or grow over the cornea. Am I clear? Moving on to the next image, everyone. Okay, which instrument can be seen in the image? Okay, this is pretty easy, I hope. What are they measuring? Are they measuring our size of the temple, right? From the left side to the right side. Are they measuring this? From the lateral canthi to the lateral canthi? No, they are not measuring this. If you think this, then you have never seen such a photograph, never read the topic. Yes, you are revising, guys. You should have known this. Yes, you do know this. I know. This is called as Hertel's exophthalmometer. Hertel's exophthalmometer. Exophthalmometer is telling you the use. What is the use of Hertel's exophthalmometer? So the use of Hertel's exophthalmometer is that you measure exophthalmos or you measure proptosis. Am I right? Can you tell me another name which is used that is called as Lewitt's exophthalmometer? That is not shown in the photograph here. That is usually used in the pediatric age group. But we are measuring proptosis. How is proptosis measured? From the lateral orbital rim margin to the anterior most point of the eyeball. That is how we measure this. So this is a Hertel's exophthalmometer proptosis, right? Moving on to the next image, guys. Okay, wonderful. Diagnosis. Without the options, sir, this is very difficult. Okay. Okay. So let me give you, first of all, description of the image. How will you describe this image? What all can you see? Sir, we can see redness. No, don't say we can see redness. Redness is a symptom. Sir, we can see congestion. Conjunctival congestion. Okay. What else can we see, sir? Very important thing. What else can we see? We can see swelling. Okay, sir. Sir, the left eye is not able to open. Left eye not opening completely. But if you understand why are all these things happening, what is the main thing you can see? The main thing you can see is the same thing that we have discussed in this image. Can you think about it? Can you see it? Yes, I think you can. Yes, sir. We can see that the eyeball has protruded out. It's looking like it's bulging out. It's popping out as if I'm watching a Tom and Jerry cartoon. Yes, so it's a proptosis. So now we are talking about a case of proptosis, which is bilateral. Proptosis, which is bilateral, which has a lot of congestion. Along with congestion, we have swelling. And as we know, swelling of the bulbar conjunctiva is known as chemosis. Okay. Rest of the things we can't see. We can't see whether there is restriction of ocular movement or not. We can't see whether the trigeminal nerve is involved or not. We understand this. So basically, we are discussing a case of proptosis. But if we understand based on congestion, chemosis, left eye not opening, swelling, all that, we are discussing which causes of proptosis. We are discussing inflammatory causes of proptosis. See, there can be vascular causes of proptosis like keratoconus fistula or orbital varices. We are not discussing them, right? We are discussing inflammatory causes of proptosis. You understand how to proceed in such a question? I know as soon as we see orbital conditions, we are not used to seeing images of proptosis, not answering questions on proptosis. In my experience, a lot of students find it very difficult. That's why I'm trying to break it down for you. When you see this image, what are you going to see? You are going to see, first of all, the signs. You think as if you're sitting in the OPD. If you're sitting in the OPD, you're evaluating the patient. You're seeing the patient, you're making a differential diagnosis. That's what I'm doing. I'm saying it's a proptosis, but there are signs of inflammation, so it's an inflammatory proptosis. Now, inflammatory proptosis, there can be three causes. If you don't remember, I have written them for you. Orbital apex syndrome, cavernous sinus thrombosis, and orbital cellulitis. But because I know I have read my theory, now it becomes a case of inflammatory proptosis. I just need to remember my theory. And I am not writing any theory. I am writing just what is visible to me. I know orbital apex syndrome is unilateral. I know orbital cellulitis is unilateral. The only condition which is bilateral amongst the three, obviously it starts unilaterally, but it becomes bilateral later on. That is cavernous sinus thrombosis. Also, I know orbital apex syndrome has mild chemosis. If it has mild chemosis, both the points go against it. Cavernous sinus thrombosis and orbital cellulitis both will present with marked chemosis. But because bilaterality is seen in the image, that is why my answer without a doubt becomes cavernous sinus thrombosis. All right, sir, what about the other clinical features of orbital apex syndrome, cavernous sinus thrombosis, and orbital cellulitis? That is good for theory, but as I said, in the image, nothing else is visible to me. I cannot see which nerve is affected. I cannot see whether trigeminal nerve is affected. I cannot see whether there is edema in the mastoid region. Those are all the differences. Ophthalmoplegia, whether it is concurrent, whether it is sequential, whether the loss of vision is there. Second nerve is affected in orbital apex syndrome, but it is not affected in cavernous sinus thrombosis. All those things I cannot see, so I'm not basing my diagnosis on all of them. I'm just looking at the photograph and reaching the diagnosis. So what is my wonderful diagnosis? My wonderful diagnosis is cavernous sinus thrombosis. The day is not far when you will get this photograph. Lot of theory-based questions have been asked on these inflammatory proptosis. I don't think till yet in my memory an image-based question has been asked. So look forward to it, right? Moving on to the next image, guys. Okay, we have entered squint territory. Okay, so we have been given three images of the same child. This is the primary gaze. This is levo elevation. Levo means left, dextro elevation. Dextro means right. So three images have been given. First, primary gaze looking straight. Then levo elevation. Obviously, this is the right eye, this is the left eye. So levo elevation means the child is trying to look in this direction. And then we have dextro elevation. Dextro elevation means the child is trying to look in this direction. All right, everyone clear about this? Now, once we see this photograph, first of all, what is the sign, then what is the diagnosis they have asked, and then what is the test. So sign we need to evaluate anyways. Let us try to evaluate it. In the primary gaze, are both the eyes looking straight? Yes, more or less, I think, sir. It looks a little bit of hypertropia. Okay, but I will say the primary gaze is normal, looks more normal to me than anything else. Now, levo elevation. Are both the eyes looking up and towards the left side? Are both the eyes looking up and towards the left side? I will say yes. Levo elevation is normal. Yes, it is normal. Now, when I look at dextro elevation, I look at the right eye. The right eye is up and towards the right side. But when I look at the left eye, I see the left eye is towards the right side, but it is not able to elevate. Am I clear? No elevation. Can you see this is elevated, this is not elevated, this is just adducted. So my sign is loss of or limitation of, whichever way you want to put it in words, elevation in adduction. Obviously, which eye are we talking about? We are talking about the left eye. So left eye, there is loss of elevation in adduction. Now, if there is loss of elevation in adduction, which muscle has the function elevation in adduction? Adduction, elevation, elevation in adduction. They're talking about elevation. So elevation is done by two muscles. What are the two muscles elevation is done by? Superior rectus and inferior oblique. But superior rectus is predominant in abduction. Inferior oblique is predominant in adduction. Yes, you have to think about that. So that means there is somewhere an IO problem. inferior oblique problem. That is what I narrow myself down to, that there is an inferior oblique problem. Does that mean there is an inferior oblique palsy? Can a individual inferior oblique palsy occur? No, sir. Inferior oblique is supplied by the third cranial nerve. If third cranial nerve is damaged, a lot of muscles will be damaged. That means if there is inferior oblique palsy, your diagnosis is wrong. I am going to say there is inferior oblique restriction. Why is there inferior oblique restriction? Due to my diagnosis, that is Brown's syndrome. What is Brown syndrome, if you remember anyone? Brown syndrome is congenital contracture of superior oblique. Superior oblique contracture leads to inferior oblique restriction. Why? Because the superior oblique is contracted, the inferior oblique is not able to contract. Inferior oblique contraction will require superior oblique relaxation. So, even though the problem is in superior oblique, Brown syndrome, I hope you remember this, even though the problem is in superior oblique, the manifestation is in inferior oblique. Am I making myself very clear? And that is what this photograph is showing you. What is the test? Now, why are they asking us a test, sir? Because we are discussing a case now of restrictive squint. So, what is the test used to diagnose cases of restrictive squint or to differentiate restrictive squint from paralytic squint? The answer is forced duction test, FDT. I know squint images are difficult, but see, that's what the key is. That's how I am trying to do it for you. First, see what is happening, then think about the muscle, then think about the diagnosis. Obviously, you need to know your theory to be able to do this, right? Moving on to the next image, everyone. All right, an easy image now, no more squint. What are the signs visible and what is the diagnosis? What are the signs visible? All right, let us see the image. First of all, we see that there is a hazy cornea, but in the hazy cornea, there are a lot of deposits or dots on the cornea. I hope this whole area we can see a lot of deposits or dots on the cornea. Yes, not a very good image, but nonetheless, you can see it. So, what are these, everyone? Yes, sir, we know them. These are keratic precipitates. Now, as soon as I know keratic precipitates or KPs, I know KPs are found in only one disease, that is anterior uveitis. So, my diagnosis becomes pretty clear that it is anterior uveitis. But what is the other sign you can see in this photograph? Let me just erase the red circle I have drawn. Look at the pupil. Even though very hazy pupil you can see, is the pupil dilated, is the pupil constricted, or is the pupil dilated somewhere, constricted somewhere? Yes. So this very hazily you can also make out a festooned pupil. So that means these are the two things visible which are clear enough, diagnostic enough for us to be able to reach our diagnosis of anterior uveitis. Please remember, anterior uveitis is also called as iridocyclitis, inflammation of iris and pars plicata. All right, back into squint territory. Next image. Same thing. Let us see the sign or the findings, and then we will try to understand or reach the diagnosis. Okay, findings first. But sir, why so many images? So these are the 9 cardinal positions of gaze. In this, basically, the center photograph you should see first because it is the primary gaze. Then obviously this is the up gaze, this is the down gaze, this is levo version, this is dextro version, dextro elevation, dextro depression, levo elevation, levo depression. Okay, this is primary gaze. These are secondary gazes. One more question we are revising here. The plus sign, the up, right, up, down, left, right are secondary gazes, and then the diagonals are the tertiary gazes, right? So the 9 cardinal gazes have been shown to you here. Now, first of all, we need to see in the primary gaze, can we see any abnormality? If we are able to see some abnormality in the primary gaze, that is our, I think, half job done. So can you see something in primary gaze? Very clearly visible to you. Very clearly. Anyone? Anyone? Right eye or left eye? Okay, very good. I am hearing right eye hypertropia. Try to see carefully. You will be able to see that the right eye level is up, elevated compared to the left eye. How, sir? I cannot see any sclera in the left eye in the inferior portion. But if we see carefully in the right eye, I can see inferior sclera, and that is giving me a clear indication. Otherwise, if you just focus, you can see that the right eye is up. Yes. So right eye hypertropia. Now, as soon as I hear hypertropia, the first diagnosis that comes into my mind is, in whatever little I have read about squint, fourth cranial nerve palsy. Oh, tongue. So the answer is here. But still, let us confirm. Okay. So now, if it is a superior oblique palsy, that's what we are aiming at, then superior oblique's function is, we need to think hypertropia, but the hypertropia, there is elevation. No, 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 no. Hypertropia increases during adduction. That's what we had read, or something like that. Let us see, sir. So, if we are presuming it, let us confirm it, guys. How do we confirm it? We look at all the adduction positions of the right eye. Adduction positions of the right eye. Here we see that the right eye adduction has elevated, but the elevation is much more than the left eye, because inferior oblique is overacting. Similarly, if we see this image where there is only adduction of the right eye, along with reduction, there is slight elevation. Similarly, we see that the depression during adduction is a little weak. All right. So we know, because it is right hypertropia, our diagnosis is right eye superior oblique palsy or fourth cranial nerve palsy. I hope we are pretty clear about this. There is no confusion in this. Moving on to the next image, please. Okay, so this question, this is asking us which surgery is this and which step of the surgery. Next question. So which surgery? Anyone can make out which surgery. Are we operating in the cornea? No, we are not. Obviously, sir, we are operating in the lens. Obviously, sir, this is cataract surgery. This is phacoemulsification. I don't think anybody should have a doubt. We have a beautiful video in our Marrow videos showing a complete cataract surgery where you have seen such an image. What is this instrument? This is the phacoemulsification probe. Phacoemulsification probe converts ultrasonic energy into mechanical vibration. I hope you remember this. Now, which step is being shown here? See, the nucleus is being sculpted into. Can you see, everyone? The nucleus, there is a sculpt. We are trying to groove it out. Where are we trying to groove it out? We are trying to break it into smaller pieces. That means this is nuclear fragmentation. After we do nuclear fragmentation, then we do aspiration. Nuclear fragmentation. Okay, or sometimes we also call this sculpting of the nucleus. That's the step here. All right, everyone, am I clear? Let us move on to the next image. Again, a phacoemulsification image has been given to you. Which step is being done and which dye is used? First of all, let's see which dye. So we have used a blue color dye. What is the blue color dye? All of us know this. This is a trypan blue dye. What is the use of this trypan blue dye? This is used to stain the anterior capsule of lens. Why do we stain the anterior capsule of the lens using trypan blue dye? That is the step, because we want to create a window in the anterior capsule of lens to be able to take out the nucleus and to implant an IOL. So what is the step known as? The step is known as CCC. You can see a continuous curvilinear capsular axis. A round window has been created. You can see the forceps and you can see the torn part of the anterior capsule. So what is CCC? Continuous curvilinear capsular axis. This is one of the most important steps of the surgery, because this is probably one deciding factor and a step which takes little time to be able to master. If CCC goes wrong, then your surgery invariably will go wrong. There are going to be complications, and that is why a lot of questions get focused on CCC. There was a question on CCC versus can opener capsulotomy. CCC is completely round, so there is no vertical force which can tear the capsule, but can opener gives multiple cuts. So this is how a can opener rexis will look like to you. Like in the olden times, we used to open the cans, right? Zigzag, zigzag, zigzag. So now there are vertical forces which are applied. So when you're stretching, this may completely spread out. The capsule may completely rupture, PCR, posterior capsular rupture. And that is why CCC is a much better form of entry into the anterior capsule. All right, everyone. Moving on to the next image, what can we see here? Okay, what can we see here? Let us try to see carefully. We can see some shining light here. No, this is not what we are focusing on. Let us focus on to the cornea. Does the cornea seem completely transparent to you? No, not at all. Sir, the cornea seems little hazy and it looks as if there is a fern-like plant, right? So we call it whorl-like opacities. Okay, a vortex forming. If you know, those tornadoes which come, they have a starting point and then they circle out. Yes, so this is looking like that. It is looking like that whirl. So whirl-like opacities, this is called as vortex keratopathy. Vortex keratopathy. Am I clear about this? Now, so vortex keratopathy we can see starting from here, then spreading out fern-like. Now, the second question that is asked is, what are the causes of this? So, for the causes, please remember one important drug, and that important drug is amiodarone. Amiodarone very commonly is responsible for vortex keratopathy. Secondly, 90% cases of Fabry's or Fabry's disease, they also lead to vortex keratopathy. Now, why am I posing this image to you as an important question? Because one important group of anti-glaucoma drugs which has come into use recently, now it is being more used in practice, those are the rho kinase inhibitors, nitarsudil. Rho kinase inhibitors have also shown propensity for the patients to cause vortex keratopathy. Am I clear about this? So this is a potential question in your future. Now this image, everyone, what is the diagnosis? A similarish image, as I have been told, was asked in the recently concluded INI-CET May 2025 exam also, though there was a little controversy surrounding it, but this image had been asked actually 5-6 years back also. This is a very simple image. If you have any confusion, let me just go through it quickly. Baseline. Baseline means primary gaze. In primary gaze, both the eyes are straight. There is no problem. Normal primary gaze. This is right gaze. In right gaze, again, I don't see any problem. Both the eyes have moved towards the right side. Normal. Now, left gaze. What do we see in the left gaze? We see in the left gaze that the left eye has performed abduction. Left eye abduction is normal, but the right eye adduction is absent. So my right eye adduction is absent. Okay. That means there is a problem in right eye medial rectus. But sir, if right eye medial rectus is having a problem, is third cranial nerve palsy the answer? No, sir. Again, third cranial nerve palsy isolated is very rare. Yes. Then I need to think about what structure in my neural system, my brain controls the medial rectus. So I know medial rectus is controlled by medial longitudinal fasciculus, MLF. That means I think about gaze now. This is a case of left gaze defect. Left gaze defect due to right eye MLF lesion. MLF lesion leads to contralateral gaze defect. It is as simple as that. Also, there is a key giveaway word, and that giveaway word is nystagmus. Because one eye has gone towards the left side, the other eye has not been able to go towards the left side. The eye which has gone towards the left side, that is coming back, going again, coming back, going again, coming back, going again. It is like it is calling, I have gone, please come. I have gone, please come. I have gone, please come. Are you getting my point? That is why it keeps showing nystagmoid movements. But the right eye, because the MLF is not giving the signal to the medial rectus, the right eye is not moving. The left eye is performing nystagmoid movements, going out, coming in, going out, coming in, going out, coming in. I hope we are clear about this. Yes. So this is a very simple lesion. This is known as right side internuclear ophthalmoplegia. Right eye internuclear ophthalmoplegia. And the most common cause is multiple sclerosis. As simple as that. I hope I'm pretty clear about this. Sir, is there something called as reverse internuclear ophthalmoplegia? Yes, there is. But that is so rare that I don't think that should ever be asked to you. Okay. See, anything can be asked to you. But when we are making an examination, we want to ask you things which you will encounter, not which will only be written in textbooks as one case was seen, 10 cases were seen in the past 10 years. No, we are not wanting to do that, right? Next, move on, please. All right, so we are asking you to identify lesion number 1 and lesion number 2. Pretty simple. Spot diagnosis is if you can do it. Spot number 1, spot number 2. Spot number 1 is pretty easy. What can we see? A black arrow is marked and there are some 3 structures, 1, 2, and 3. What are these and where are these? See, they are at the pupillary margin. Yes, if they are at the pupillary margin, some kind of nodules, my mind goes to Coppe nodules. Yes, Coppe nodules, pupillary margin. Coppe nodules, pupillary margin. As simple as that. Now the second image. The second image is a more difficultish image. What can we see? We can see two things here. Number one, I can see this. I can see a small posterior synechia has formed. Yes, I can see this. But number two, I think the examiners are not asking me posterior synechia here. They are trying to ask me something similar to Coppe nodules, which we can see, I think, here. What are all these which I have drawn? I'll rub them for you now so that you can see. I'll erase them, not rub them. Bad English choice, but nonetheless. So what can we see here? We can see Busacca nodules. Busacca nodules are the other type of nodules. Both these nodules are found in uveitis, or rather I can specifically say anterior uveitis. As we all know, Busacca nodules are found in the stroma. So we can see not at the pupillary margin, but all the nodules in the iris stroma. Yes. Now, moving on, guys. Another image. Okay. These are also nodules. We've been asked to identify and find out the cause. So we can again see it's a light colored, gray colored iris. And we can see a lot of brown nodules in the stroma. So are they also Busacca nodules? No, they are Lish nodules. See, the difference between Lish nodules and Busacca nodules are, number one, Busacca nodules will be found in anterior uveitis, so there will be a lot of other findings, like I showed you, posterior synechia is formed, right? Then there can also be keratic precipitates and other findings. Secondly, Lish nodules are flat. They are not elevated. Busacca nodules are slightly elevated and they are smaller than the Lish nodules. Also, we know that the cause of Lish nodules is neurofibromatosis. So it is a phacomatosis where you will see all the other clinical features of neurofibromatosis. All right, moving on. Okay, we've gone back to fundus. Identify the lesion and the causes. Now, what can you see? You can see again those yellowish dots. Yes, you can see a lot of yellowish dots. Yes or no? I think I can. 1, 2, 3, 4, 5. Lots of. Can't keep on counting them. See? Lots of scattered peripheral, not central. The center is clear enough. A lot of deposits yellow color. Again, these are called nodules. These are called as Dahlen-Fuch nodules. Now, Dahlen-Fuch nodules can be found in two conditions. VKH syndrome. What is VKH syndrome? Vogt-Koyanagi-Harada syndrome. And obviously, the other is sympathetic ophthalmitis. A lot of students who read the textbooks, see, that's also very important to say, who read the textbooks. These days, I think textbooks are becoming, what do you say, rudimentary or, kind of devices. Not because you are reading something online, you're just not reading. Yes, you're just watching the videos. I'm not saying that's bad, but yes, right? So VKH syndrome and sympathetic ophthalmitis, both of them are having Dahlen-Fuch nodules. But this seems to me more as a case of VKH syndrome because along with Dahlen-Fuch nodules, I see a sunset glow fundus. As soon as you first saw the photograph, didn't it look like a beautiful sunset, an orangish glow? Yes. So Dahlen-Fuch nodules along with sunset glow fundus gives you VKH syndrome. Obviously, such an image, if it comes only by itself, then they will examine this trying to ask you Dahlen-Fuch nodules. But if there is some kind of a examination given along with it, then they will either be pushing you towards VKH syndrome or towards sympathetic ophthalmitis. Please remember, VKH syndrome and sympathetic ophthalmitis both are causes of which disease? Yes, pan uveitis. All right, everyone. No confusion, I hope. Let's move on to the next image. Okay, two images given, and it is asked which procedure has been done, and this procedure is used in. Okay. So what do we see? Which procedure? What can we see here in both the eyes? What is the similarity? Okay, I can see the similarity. I'll just point it out for you. This is what I can see. One more clearly, one less clearly, but yes, both. What is this? A hole in the iris. This hole in the iris is probably about to close, but this is more patent. So the procedure that has been done is laser iridotomy. Am I correct? Laser iridotomy is done using which laser? Yes, sir. It is done using ND-YAG laser, neodymium yttrium aluminium garnet. ND-YAG laser. Okay. Now, this laser iridotomy is used in which condition? That's the question. Now, also we can see one more thing. We can remember that laser iridotomy, the hole is usually made between 11 o'clock to 1 o'clock. You can see the position of the hole is almost correct in both the eyes, and it is used in angle closure glaucoma. It is the treatment of choice for angle closure glaucoma. I hope there is no confusion in this. Right, guys? Done. Moving on forward. Again, procedure, again a similar image. Is it also laser iridotomy? See, I think it looks the same. Is this also laser iridotomy? Sir, what is the difference? Sir, it does not look like a hole. It is a V-shaped opening. Oh, sir, some other surgery has been done. Sir, is it trabeculectomy? No, sir. Don't think too much, sir. There is a cut in the iris, just like a hole in the iris. Instead of laser, this is manual. That's all. This is called as iridectomy. Either the case was being operated for some other thing, let's say cataract, phacoemulsification was being done, or it may have been that you did not have access to the laser. So you went in means you did a surgery, you've cut the periphery of the iris with a scissor, and that is all. Iridectomy. Same thing. That's what I'm trying to show you. Not necessarily everything needs a laser. Before lasers were invented, surgeries were done manually only. So just like laser iridotomy is there, a hole in the iris, we can do an iridectomy also. Same funda, same use, allows the aqueous to flow from posterior chamber to anterior chamber, thus maintains the pressure, intraocular pressure, and does not let the angle close. Am I clear about this? All right, thank you. Now, okay, neuro-ophthalmology, identify the visual field defect. Obviously, see, visual field defect is for yourself. So this is the left eye, this is the right eye. You should first of all understand this. Now, what visual field defect can be seen? Anybody can make out. Both have same. Yes, it is same. So it looks like altitudinal visual field defect. Sir, why altitudinal visual field defect? Because it is respecting the horizontal midline. But I have a better answer. I don't think this is the answer. See, this is the optic disc, obviously. So the optic disc is a physiological blind spot. So if I roughly trace the loss of vision in both the eyes, obviously, see, you have to give it a little leeway. Some areas may be completely black, some may be slightly whitish. It looks like this. Sir, what does it look like? Yes, sir. It looks like arcuate scotoma. Arcuate scotoma, also known as B-Yerum scotoma. Yes, arcuate scotoma or B-Yerum scotoma is a kind of altitudinal visual field defect only because it is happening only in the superior part of visual field. So ideally, any of the options, all the three names given on the screen would have been correct. Yes, obviously, arcuate scotoma or B-Yerum scotoma is found in which condition? Glaucoma, we know. The earliest visual field defect being isopter contraction, then onto paracentral scotoma, then onto sedal scotoma, then onto arcuate, and then if it would have been a complete circle, inferior arcuate, superior arcuate, then we would have said it is a ring scotoma. I hope you remember this. Yes. So please remember, very simple way to understand. Don't try to think too much. Now, next question again. Identify visual field defect. Okay, again, let's do the same thing. Let us take a red pen and let us see what is lost. This area is lost, more or less. Similarish. So slightly going down, but okay. What can we see? We can see in both the eyes, in the left eye and the right eye, right side of vision has been lost. If both eyes right side is lost, first of all, I can write which word? Homonymous. Can I write the word homonymous? I hope yes. I hope you understand I can write the word homonymous. But it is which side homonymous? Right side homonymous. Right side homonymous. But only which homonymous? Superior quadrant anopia. Or if I write simply, can I say this is right side pie in the sky? See how easy it is. We are just used to, learning the names and not seeing them in the photographs. That's why we take time. This is right side pie in the sky. So if I ask you, where is the lesion? Let me ask you, sir, where is the lesion? What will you answer? If it is right side pie in the sky, sir, the lesion is in left eye. Or rather left side, I will say. I will not say left eye. The lesion is in left inferior optic radiations. Or can I say the lesion is in left Mayer's loop? I hope we are clear about how to solve such image questions. Yes, these image questions or such image questions are on the rise. Now they are not asking you theory, they are just giving you a photograph and they're asking you to diagnose based on the report which has been produced by the machine. I know AI has come, the machines give us the answer also, but at last you are the doctor. You should be able to confirm or deny the findings of the AI machine. The AI takeover is near. Don't let it proceed. Moving on, guys. Okay, very easy question. What is the test shown in the photograph? I don't think anybody will get it wrong. This is Ishihara chart. Obviously, we know that Ishihara chart is used for color vision testing. It is the most commonly done test, but it has the drawback that it can not detect Tritan problems. Tritan means which color, guys? Very good, sir. Tritan means blue, sir. All right. That is why it is not the ideal test. What is the most significant, best test, ideal test? That is Farnsworth-Munsell 100 hue test. All of us know that, right? Now, let us move on. Identify this diagram. What is this diagram? This diagram is known as, this diagram, all of you know this, you don't know this. This is pretty simple. This is known as Sturm's conoid. What is Sturm's conoid? That's the question. What is Sturm's conoid? Anybody can answer. What is Sturm's conoid? Yes, Sturm's conoid is the projection of light rays when refraction occurs through toric surface. Toric is a spherocylindrical or a cylindrical surface. Yes or no? Do you understand this toric surface? Yes. So what are we trying to say? That in toric surface, the vertical and the horizontal power are different. So the refraction occurring from the vertical axis and the horizontal axis are different. So at each point, you will see that the vertical light rays or the horizontal light rays, either they are converging or diverging, but not the same. So we try to position the lens, or when we give the power of the toric surface lens, we try to give the power in such a way that the image forms at point D, which is called the circle of least confusion, because here we are saying we are getting equal amount of or equal and opposite amount of convergence and divergence by the horizontal and vertical light rays, such as at point F. At point F, we see that the vertical light rays are completely converged to a point source, but the horizontal light rays are diverging a lot. So this is not the ideal point of focus. So the ideal point of focus is point D, that is the circle of least confusion. I hope I'm clear about Sturm's conoid acting on the toric surface, right? Or a diagrammatic representation of the refraction through a toric surface. Moving on, please. Okay, next question, diagnose. What is this? We see a blood vessel supplying some kind of brownish colored patch on the conjunctiva. Am I describing it correctly? Now, this is a very common presentation in the OPD. A lot of parents come with their children showing this, sir, this brown mark has appeared and there is a blood vessel which is supplying it. Now they go on Google and they think it is a tumor. But when they tell me it's a tumor, I say, yes, it is a tumor. You are absolutely correct. It is a tumor, but it is a benign tumor. This is more like a birthmark. This is just a pigmented benign tumor. This is called as conjunctival nevus. Now, conjunctival nevus, this usually occurs in either childhood around like 7-8 years of age or in early adulthood, like somewhere between 8 to 20 years of age. This is usually when it appears. Parents usually bring their children, but we are not afraid of it. This is like a mole. I have a mole on the top of my nose. I'm not concerned about it. Yes, it's a birthmark almost. So similarly, that is how we explain to the patient, please do not worry about it. Unless it starts to grow, it becomes pedunculated, it becomes like a papilloma or something, which it will not. This is a conjunctival nevus. What is the treatment? If the patient wants it, you can simply excise it, right? It is just a cosmetic blemish, that's all. So cosmetic treatment, nothing else. Okay, moving on. Next question. In this image, what is the diagnosis? Okay, so this is an image, obviously, of what? I'll just give you a clue. This is post cataract surgery. Cataract surgery has been done in the patient. See, you can see this. This is what been made. CCC, continuous curvilinear capsular axis, has been made already. This is a post cataract surgery patient. Now, what is the problem they are trying to show you in this photograph? They are trying to show you that apart from the CCC, behind it must be the lens, obviously, the remaining part of the anterior capsule that you had left has completely become opacified. So, anterior capsular opacification post cataract surgery, but it is not only opacification because it is fibrous tissue, it is contracting. So, the diagnosis becomes anterior capsular phimosis. Okay, fibrotic tissue leading to contracture, anterior capsular phimosis. Obviously, there is opacity of the anterior capsule. Now, what is the problem? If the anterior capsule is getting opaque, what is the problem? The problem is not due to the opacity. See, the light is going to go in from here in the center. The problem is not the blurring of vision. This pupil has been dilated pharmacologically. Very rare to get such a high dilatation in normal conditions. Even at night, your pupil does not dilate to 8 mm. Yes. So, what is the problem? The problem is that phimosis is leading to contraction, contracture. Contracture, when it is occurring inside the capsular bag, there is IOL. So, the contracture leads to IOL, dislocation or decentration, if I can say. That is the problem, and that is why patients usually land up in astigmatism after that. Because due to decentration, the axis of the IOL is changed, the position is slightly left, right, up, or down, and people land up with some kind of astigmatism. They need now a spectacle to correct the vision back to normal, that is 6/6. All right. So, this is a photograph of anterior capsular phimosis. This is not a very common complication. Usually, the photographs that are asked are of posterior capsular opacification, as has been shown to you. But just to understand, just like there is PC, there is AC also. Just like PC can become opacified, AC can also become opacified. And yes, we do see this, especially in cases it's done by beginner surgeons. Now, moving on to the next image, they are asking you which IOL. Now, it is a special type of IOL, I'm telling you off the hook. This is neither an AC IOL nor a PC IOL. We know that. Now, what do we see? First of all, we see that the IOL is in anterior chamber. So my first clue goes to whether it is an anterior chamber IOL. I've already told you it is not, but I'll just quickly revise with you. We had seen a photograph also, I think, that it should have an S-shaped haptic. But if we see this is the optical area. And then there is some kind of, I can say, a hook. Can you see? This is the kind of shape. I'll just rub it for you, erase it for you, so that you can make it out more clearly. This is a special IOL. This is an IOL, which is called as iris claw IOL. iris claw IOL. And this is the kind of design it will have, like this. Then hooks which will claw like a crab, like this. So the hooks, they are very nearby. Obviously, I have to make them more nearby. Then you just tuck them and you pinch them in the iris tissue. That's all you do. And the iris remains stable. Iris claw IUL can be put in or implanted in AC or in PC. That is the sulcus, behind the iris or in front of the iris, both. If done properly, no, it will not fall down. So does it restrict the dilatation or constriction of pupil? No. We are just using a little part of iris to pinch it. We are not cutting the iris. We are not damaging the muscle, not in any way. And we are just doing it in the stroma of the iris. That's all. All right. Now, next question. Next image rather. Diagnose. Pretty easy, I think. First of all, this is an oblique slit lamp image. We have seen lots of such images, I would presume, oblique slit lamp image. If not, let us quickly revise. The light is being thrown from this side. So the first slit is shining on the cornea. You can see the corneal thickness from the epithelium to the endothelium. Then we have a large black area. This is your anterior chamber. The pupil must have been dilated. That is why you cannot see an orange line. And after that, you see this is the whole lens. You can see the anatomy of the lens, the capsule, the cortex, the nucleus. Now, what do we see in the lens here? That's the question. That is the diagnosis, I think. In the lens, we see that the center of the lens has become yellowish. Yes, center of the lens means nucleus. So my diagnosis, sir, becomes that it is a nuclear cataract. It is not blood orange or brown in color, so it's not highly progressed, sir. It is probably an early stage of nuclear cataract, probably a nuclear sclerosis grade 1 or nuclear sclerosis grade 2, more likely, sir. All right, that is how we see on a slit lamp the stage of the cataract, which type of cataract. That is what we actually do when we are examining a patient as an ophthalmologist. Now, the question is, if this image was given the pathology seen in the photograph, what is the refractory error? So basically, they are asking you which refractory error is caused by nuclear cataract. So all of us may remember or should remember that it causes index myopia. Index myopia because nuclear cataract leads to increased density of the nucleus, which leads to increased refractive power, which leads to index myopia, and index myopia can cause second sight phenomena. Now, similarly, if you remember the theory, it would have been easier to diagnose this image because we know what is the color of nuclear cataract. The color of nuclear cataract is yellowish. Yes, this is what we have read in our theory, and this is what is seen. The lens has lost its transparency, it has become yellowish, and that is the basis of solving this, apart from the fact that you need to know that this is an oblique slit lamp image. All right, am I clear? Moving on to the next image, everyone. What is the sign visible in this image in the child? And what is the diagnosis? Oh, pretty easy. So diagnosis though is pretty easy. Look at the left eye. Sir, ptosis. But if you say ptosis, I will say fail. Because I know everybody can see ptosis here. Even I think a first year undergraduate would have heard the ptosis. But which ptosis? That is the important keyword. You are missing a word here if you're saying ptosis. And you can fill in that blank only when you know the sign. So, what is the diagnosis, sir? The diagnosis is congenital ptosis. What is the sign? The sign is absent upper eyelid crease. I hope I am clear. If I close my eye, if you look at my eye, please zoom onto my eye. You will see even after I've closed my eye, there is a fold of skin visible as a line in my upper eyelid. My upper eyelid is not smooth. But if you see the child, the upper eyelid is absolutely smooth because it is congenital ptosis, because the child was never able to open the eyes. This skin never folded and this upper eyelid crease never formed. So that is the diagnostic sign, absence of upper eyelid crease. Even in the right eye, you can say, though a milder degree of ptosis is seen in the right eye. So bilateral congenital ptosis due to absent upper eyelid crease. That is the simple diagnosis in this photograph. I hope you are clear about this, right? Please remember that surgery is dependent on the amount of of ptosis. In severe ptosis, we do a frontalis ring surgery. In moderate ptosis, we do something called as LPS resection. Whereas in mild ptosis, we do Fasanella servate surgery. So that is just a theoretical question. The image base you can see here. Okay. Now moving on, please. Okay. Okay. Green colored dye. Green colored dye. Which dye is it? Green colored dye, sir. We know it is fluorescein dye. Yes or no, sir? But no, sir, no. Fluorescein dye illumination is blue and it is almost like a green. This is almost like a teal color I can see. I cannot see a green color here. What is this, sir? This is not fluorescein dye, sir. No, sir. No. We have seen fluorescein dye, sir. This is lissamine green stain. What does lissamine green dye do? Lissamine green dye does the same job as rose Bengal dye. It stains necrotic tissue. Okay, dead, devitalized tissue. In simple English, dead and devitalized tissue. So, sir, where is it used? It is primarily used in cases of keratoconjunctivitis sicca. Or if I can say, keratoconjunctivitis sicca is dry eye due to aqueous deficiency. What we say, dry eye. I have dry eye, sir. I get tens of messages every day. I have been using a lubricant you are using because you have aqueous deficiency. The most common cause of keratoconjunctivitis sicca, dry eye aqueous deficiency, is Stevens-Johnson syndrome. I hope I'm clear about this, right? Now, why are we not using rose Bengal dye here? Why are we using lissamine green dye? Because lissamine green dye is better tolerated by the patient. It has less irritation. Rose Bengal has more chances of irritation. Now, what do we see? We see conjunctival cirrhosis. Due to dry eye, there are a lot of spots. Can you see all these spots of green? Can you see all these spots of green? These are all spots of green. Okay. So this is telling us that there is conjunctival cirrhosis. Obviously, cornea will also be dry and conjunctival will also be dry. We are not looking at corneal ulcer only. And that is the main purpose of lissamine green dye. It helps us to grade keratoconjunctivitis, mild, moderate, severe. Obviously, there are lots of grading schemes. Not going into that detail. I hope we are pretty clear about the image. This image is a very likely image to be asked moving forwards. Dyes are important. We need to know how and when to use them. All right, everyone. Moving forward, please, to the next image. This is the last image of our session. The last image of our ophthalmology image-based revision session as the last minute revision for your postponed NEET-PG. I hope you have been able to gain something from it. Let us gain something more. What is the diagnosis? Pretty simple image I put at the last. Yes. What can you see? Sir, simple. I can see tortuous blood vessels. Sir, I can see some fibrosis. No, don't look at all that. Look at the main thing that the examiner is asking you. Look at the optic disc. What can you see in the optic disc? You can see blurring of disc margins. And at first look, it is pretty clear. It looks like a swollen optic disc. So the diagnosis is pretty clear. It is a case of papilledema. I don't think there is any confusion in this. The normal optic disc is pretty sharp. You can see the complete optic disc margin. You can see the optic cup. It does not look elevated. It looks elevated, swollen. I think that's pretty easy. Papilledema. Now, all that I want you to do is revise papilledema with me quickly. What is papilledema? Edema of the optic disc. No, edema or swelling of the optic disc due to raised intracranial pressure. Yes, it is due to raised intracranial pressure. Almost always. Yes, bilateral, but it does not cause any loss of vision because optic disc is also known as the blind spot, but it shows you something called as hemorrhagic fugax, that is transient loss of vision. Okay, and we can call papilledema also as enlargement of blind spot if we are talking in terms of our visual field charting. I hope we are pretty clear about this. That's all from my side to help you move towards your goal or aim of achieving a very good result in your NEET-PG examination. I wish everybody to get rank 1. I know even if all of you get rank 1, there will be a selection criteria based on which you will get a college. I know you are worried about what will be the examination like. Will it be difficult? Will it be easy? I end my session just by saying, please do not focus on the factors which we cannot control. Please focus on what you can control. And what you can control is the relativity of difficulty. Nothing is difficult. If you have studied it, it is easy. If you have not, you find it difficult. So when you go into the exam, go with a confidence, go with a smile, go with the feeling that I will give my best today. If I give my best, then I am happy. But if I know after the exam that I could have done better, that is not the feeling I want to have. I will put the accelerator on the pedal. I will move with all my might, all my strength. It is just the last step. And after that, I am free. I am free not from the medical system, but I am free from at least preparing for my medical examinations. If you want to connect with me further, if you have any doubts in ophthalmology, as I always say, there are two ways: Facebook and Instagram. Instagram is the better way to connect with me. I am more prompt there. That is my ID, Utsav_Soj. On that profile, you will also see some more images like this, some small videos also being posted of various cases, whichever I get, to help you progress in your preparations. So if you are wasting time on social media, I say waste of time. Yes, it is a waste of time. Then at least waste time in beautiful things, looking at the eye and other subjects rather than just scrolling through the reels. Thank you, everyone. Best of luck for your exam.